NR, a 4-year, 11-month-old boy who's hailing from Kolkata, was brought to the hospital on 24th of April by his mother, who is a reliable informant. Mother comes with complaints of developmental delay since the child was 2 years of age. The mother of a 4-year-old, 11-month-old boy child comes with complaints of delayed development, which he noticed since the baby was 2 years old. So since the child is very young, there could be predisposing antenatal history, which could have led to the cause. So I would want to present the antenatal history first. The obstetric score of the mother is para 1, living 1, and 2 previous abortions. The pregnancy of concern is a booked case. First trimester, it was a singleton pregnancy. The mother was put on iron and folic acid supplementation. There's no history of consumption of any teratogenic drugs or exposure to any ionizing radiation. There's no history suggestive of eruptive fevers, and an ultrasound scan, which was done at 11 weeks, showed no abnormalities, and 2 doses of tetanus vaccines were given to the mother. Second trimester, quickening was received by the mother at 12 weeks, and she continued to be on iron and calcium supplementations. There's no history suggestive of eruptive fevers, maternal anemia or malnutrition, gestational diabetes or pregnancy-induced hypertension, maternal thyroid diseases, or any intrauterine or urinary tract infections, and an anomaly scan, which was done in the second trimester, showed no abnormalities. Next slide, please. Third trimester, mother continued to appreciate fetal movements. There's no history suggestive of any gestational diabetes mellitus, pregnancy-induced hypertension, oligo or polyhydramnios, or any intrauterine infections, or just 1 second, sir. I have to look at the PPT. Yeah. Okay. No history of pregnancy-induced hypertension, no oligo or polyhydramnios, and yes, mother received regular supervised antenatal care, and the antenatal period was uneventful. Birth history. This was a full-term baby boy whose birth weight was 3 kilograms, and it was appropriate for gestational age. The birth order was 1, and it was a vaginal delivery out of a secondary consanguineous marriage. And in the immediate postnatal period, baby failed to cry within the first 5 minutes and was immediately shifted to the NICU for further management. Neonatal history. On day 3 of life, the child developed abnormal movements of both upper and lower limbs and was given medications to control said movements in the NICU. 2 days later, the baby was shifted down from the NICU to the wards and was subsequently discharged. At 4 months of age, baby had another event of abnormal movements, which involved both the upper limbs and lower limbs. There was 2 episodes in a day, lasting for 2 to 3 minutes. It was associated with uprolling of eyes and frothing at the angle of mouth. There was no loss of consciousness, loss of bowel and bladder control, no drowsiness in the period following the above event, and parents did not seek any medical attention for the above episode. At 2 years of age, the mother visited the hospital as she noticed that her child was weak and wasn't growing when compared to the neighborhood children. So, next slide. So the child doesn't smile at the mirror, at his mirror image, doesn't wave bye-bye when waved at. The child is unable to feed himself and speaks in monosyllables. Mother notices stiffening of all the 4 limbs and finds it difficult to dress the child. There's history of absence of neck holding, and the child is unable to roll over when the mother is asked. There's no history of early hand preference. And when the mother is asked, she says that the child is unable to move an object from one hand to the other. The child cries and withdraws when pinched. No history of strabismus or squint or any other abnormal ocular movements. No history of any collection of food in the mouth. No history of facial asymmetry, nasal regurgitation.
Next slide. Next slide. We change the next slide. Yeah. No history.
Oh, sorry. Yes, sorry. So there's no history of strabismus or squint, or any other abnormal ocular movements. There's no history of collection of food in the mouth, no history of facial asymmetry or nasal regurgitation, no voice change that the mother noticed. There's no history of any bowel or urinary incontinence, no history of neonatal jaundice, any postnatal infections, no history of fall from height or head injuries. There's no history of loose stools or constipation, no history of recurrent respiratory tract infections, and no history of bluish discoloration of lips or any extremities. Family history. This is a first order child of a second degree consanguineous marriage. There's two previous histories of there's history of two spontaneous abortions in the mother. Apart from that, there is no other significant history in the family, and no such episodes in any family members or even the parents. So developmental history. So in the gross motor domain, a child is unable to hold his neck or even roll over to the other side. Fine motor, a child has achieved bidextrous reach at 8 months of age, and unidextrous reach at 10 months, and developed a pincer grasp at 4 years. Social and adaptive skills, the social smile was at 1.5 years, and baby was able to recognize mother when he was 2 years of age. Language domain, baby cooed at 2 years of age, and now speaks in monosyllables, which he gained at 4 years of age. And he's unable to speak in 2 syllables. So developmental quotient, the average developmental quotient for including all 4 domains is 8.75%. The inference for which would be, there is a global developmental delay, since there is developmental quotient is less than 70% in more than 2 domains of development. Immunization history, the child has been immunized up to date according to the National Immunization Schedule. He received birth dose of BCG vaccine, OPV, and hepatitis B vaccine. At 6, 10, and 14, he received pentavalent 1, 2, and 3, along with oral polio vaccines. At 9 months, he got his first dose of MR. And at 20 months, he got his second dose of MR and DPT boosters. So next slide. Diet history. So do you want me to elaborate everything or just the deficit?
No, only what is important you tell. Important.
Sir?
What is important, what is relevant to your case, you tell.
Yes, sir. So the total calorie consumed by the child, this is a 24-hour recall method of collecting dietary history, and total calories consumed is around is 880 kilocal, and the total proteins consumed is 24 grams, and there is a calorie deficit of 520 kilocal per day. Socioeconomic status, there is overcrowding that is present in the household. The source of water is a piped water supply. There's no open dumps near the residence, and there's no history of environmental tobacco smoking. And the family belongs to an upper lower class according to the modified Koposwamy scale. Next slide. The summary: a 4-year, 11-month-old term baby born out of a vaginal delivery, born out of second-degree consanguineous marriage, whose birth order is 1, immunized to date, belonging to the upper lower class family, is here with global developmental delay, with no decline in milestones achieved, and two episodes of convulsions, and is in calorie deficit, with history of birth asphyxia and NICU admission, and stiffness of all the 4 limbs.
Okay.
Yes, sir.
With the summary of your this one, you be the summary.
Yes, sir.
No, you are at summary, no? Summary level.
Yes, sir.
You should know what is cerebral palsy.
Yes, sir.
How will you define cerebral palsy?
Sir, cerebral palsy, it's an umbrella term used to describe a disease which has both motor and postural component, which is a non-progressive type of brain lesion due to a result of infantile or fetal brain. It's usually a non-progressive or a static encephalopathy.
Non-progressive in what way?
There is no decline or increase in the child doesn't gain any more functionality, nor does he lose whatever he has gained.
No. How to define cerebral palsy means it's a heterogeneous group of persistent. It's a persistent disorder of persistent disorder of movement and posture.
Okay.
It's a persistent disorder of movement and posture. Okay.
Yes, sir.
Causing activity limitation. Causing activity
Yes, sir.
limitation due to a non-progressive brain lesion or defects. Due
Yes.
to a non-progressive brain lesion or defect of growing brain or
Oh, yes, sir.
immature
Growing
brain.
brain.
Therefore, here the CP, the definition, if you know the definition, then you can involve so many things here. Here, what is that? It's a heterogeneous. So many things will be involved here.
Yes,
Okay,
sir.
and it's a persistent disorder. It never disappears. It persists.
Yes.
And it's
Okay,
a disorder of movement and the posture.
Yes,
It's
sir.
mainly disorder of the movement and posture.
Posture.
Okay. Then it's a non-progressive brain lesion. The brain lesion here is static. Okay. But
Yes,
your
sir.
clinical features are there, no, they are dynamic. The clinical features are dynamic, whereas your lesion will be static. That's why we
Okay.
call
Oh, okay.
cerebral palsy as a static encephalopathy. Okay.
Okay, sir. Yes, sir.
Called static encephalopathy. Why means the lesion here is non-progressive brain lesion or defects. Okay.
Okay.
Of immature brain or a growing
Yeah.
brain.
Yes, sir.
Therefore, CP is more commonly involved in the young age group.
Young age. Yes, sir.
Brain is seen in the first 1-2 years, 2 years, maximum 3, 4, 5. That's all. We
Yes.
can't tell 8 years, 10 years, 15 years CP.
Okay. Yes,
Because
sir.
it's an insult in the growing brain or an immature brain,
Yes.
which commonly lead to which is the most common cause for childhood physical disability.
Yes.
With so many comorbidities are there. Therefore, in your history, you should get all those things. Okay.
Okay.
Therefore,
Yes, sir.
how do you classify CPs?
Sir, you have one is more pyramidal, one with
No. How do
dystonic
you
CP
classify
and
means classification means you have anatomical classification, we have
okay.
physiological classification, we have functional classification, we have
Okay.
etiological classification.
Yes,
Therefore,
sir.
you should get in your history all these classifications.
Okay, sir.
What type of anatomical classification in your history you got in your
Yes. Okay, sir.
What is the anatomy here? Anatomy
Sir,
means whether this is monoplasia, whether it is a diplegia, or it
yes,
is
sir.
quadriplegia, or whether it is tetraplegia, or
Okay,
it
sir.
is hemiplegia, or it is pentaplegia. Where
Okay.
is the anatomy here?
Sir, in history, mother noticed that the stiffness of all four limbs.
All
And,
four limbs means what type of involvement?
a
What type of
quadriplegic type. Quadriplegic.
quadriplegic type? Whether all the four limbs are equally involved?
Yes, sir.
Not
It was
equally
equally
involved.
involved. Yes, sir.
Asymmetry is there. The upper limb
There's
is
no.
more commonly involved,
Okay,
or
sir.
lower limb. You got in your history?
No, so she just told that there is stiffness in all four limbs and there's no upper limb or lower limb involvement more predominant.
No, you elicit that history. Therefore, because the etiology for your quadriplegia will be different. Etiology for your hemiplegia will be different. Etiology for your diaplegia is different. That's why
Okay.
in your history, what is the anatomy? Why?
Okay.
That anatomy you should get first thing. Here
Okay,
your
sir.
anatomy is quadriplegia. Okay, in your history only you try to get all the diagnosis. Here in your history, it's you take it as CP. In that, why you take CP means there is one criteria called poster criteria.
Sir,
What is
sir,
poster
what?
criteria? Poster, POSTER, poster
Okay, sir.
criteria to
Okay.
diagnose CP. What do you mean by P means posture abnormalities? Abnormalities in the posture. Okay.
Okay.
Or movements. Okay. Then O means they'll have a oropharyngeal insufficiency. They'll have a difficulty in swallowing, difficulty in speech. Okay.
Yes, sir. Yes, sir.
Got my point?
Yes,
S
sir.
means strabismus.
Okay.
They'll have a problem with the vision. Okay, strabismus. T means tone abnormalities. E means there'll be equilibrium defects because some primitive reflexes they persist, and
Okay.
the what we call positional reflex or mature reflex will not appear. Okay, that
Okay.
is called the E. R means your reflexes. The reflexes are going to be exaggerated. Your Babin's will be positive. those things.
Yes, sir. Okay.
You try to elicit whether it fits there, whether it fits into cerebral palsy. If it fits into cerebral palsy, then whether it is a in that, what is the anatomy?
Anatomy. Okay.
What is the physiology? Physiology means what type of type will get, whether it is a spastic type, whether it is dystonic type, whether it is ataxic type, whether it is atonic type. All those things you try to elicit in the history.
Okay. Okay.
Then how much impairment is getting, that is a functional, that also you should get in the history only. How much function is impaired, whether there is no limitation of the activity, mild to moderate, moderate to severe, or no activity at all.
Okay. Okay.
And you try to, your ear etiology will be easy, whether it is a prenatal, perinatal, or a postnatal. Here you are told a birth asphyxia, most probably will take it as a perinatal insult.
Perinatal, yes.
Usually, if the birth asphyxia has the etiology, where will be the insult in the brain? Which part of the brain is going to be affected if the birth asphyxia is the etiology?
Usually the periventricular region.
Why periventricular region if there is a birth asphyxia is involved? That's why you try to. And along with this, very important is you should try to get the comorbidities of the CPs.
Okay.
What are the comorbidities? There are so many comorbidities associated with CP. Okay. In the form of cognition, in the form of communication, in the form of sensation, in the form of perception, in the form of hearing, in the form of seizures.
Okay.
Here you try to get all those things: vision, hearing, okay, then sensation, that is cortical sensations, spatial sensations, communications, that is behavioral disturbances. All those things you try to get all those things, pictures in your history.
Okay.
That you have to confirm in your examination.
Okay.
Therefore, here you should get the anatomy, you should get the physiology, you should get the functional, you should get the etiology, and along with these 4 components, you try to get the comorbidities of the involvement. And you have to know the site. Where is the site of the lesion? Where is the site of the lesion? If the anatomy, in that will come to know where is the site of the lesion. If it is diplegia, the site will be different. It is more of periventricular leukomalacia.
Diplegia, yes, sir.
Yeah. If it is quadriplegia, severe periventricular leukomalacia will be there. Even cortex will be involved, cortical malformation. If it is hemiplegia, it is more of in utero stroke or mid-cerebral artery is involved, like that. That's why you try to bring out the etiology.
Okay. Yes.
And now you go to the first slide, because all those things you should try to get in your history. Okay.
Yes.
Now we'll see whether you got those things in your history. We'll check.
Yes. Okay.
Now you wrote a NR, a 4-year, 11-month-old boy hailing from Kolkata, was brought to the hospital on 21/4/2022 by his mother, who is reliable informant. Okay, that much is sufficient. 4-year, 11-month-old boy hailing from Kolkata was brought to the hospital on 21/4/2000. You examined when you examined the child?
Sir, 1 week
came to you, on that day only you examined the child?
No, sir. It was in the ward, so week after.
Yeah, you should write that one. When the baby, whether it is a severe disease, we'll come to know whether how is the condition of the baby was in the ward for 2 to 3 days, means it's somewhat acute chronic disease.
Okay.
There only we can come to know whether it is acute disease, whether it is a chronic disease, whether any critical disease is there, like that. The baby came, and if you examine immediately, and their nature also you can get. Okay. Therefore, date of admission is important, date of examination is important, and here only you can mention the consanguinity.
Here only. Okay.
Whether that baby is born to a consanguineous people or non-consanguineous. If it is consanguineous, whether it is 1st degree, 2nd degree, 3rd degree, that is very, very important. Okay.
Yes.
Because so many conditions, like some hereditary disorders are there, like your Tay-Sachs disease, your Gaucher disease, Krabbe disease, all those things, they runs in the family.
Leukodystrophy, yes, sir.
Leukodystrophies, all those things. That's why we'll come to know whether it is a more of genetic causes. Because the most commonest cause for CP nowadays is, previously we used to thought only the birth asphyxia is the most common cause for CP. Okay, because birth asphyxia is only 3% to 10%. That's all. But
Okay.
majority of the causes will be more of prenatal causes. Prenatal causes. You got my point? Therefore,
Yes.
we have those genetic factors. Because in the prenatal, we have maternal factors, we have fetal factors, we have placenta factors.
Yes.
We try to bring out those things.
Okay. Yes.
Next, you wrote delayed developments in the age of since the child was 2 years old. What is the definition of delayed development according to you?
Sir, delayed development is, I mean, we call global developmental, when developmental quotient is less
what
than
do you mean by
70%.
developmental delay? When you
Yes,
call
sir.
developmental delay?
Sir, the developmental quotient is less than 70%.
No. When you call developmental delay, that is developmental quotient, DQ. That is different.
Yes, sir.
When you call developmental delay.
So when the child is achieving his milestones slightly, it's offset, so not at time that is needed.
Huh? No. How to define that? Because you wrote the chief complaint, because of that she came to the hospital.
Yes.
That is a presenting complaint for the hospital. You should know the definition of delayed development. You got my point?
Yes.
Then you are going to call delayed development, because global developmental delay is next. Now your question here is what do you mean by delayed development?
Yes.
How to define delayed development?
I'm not sure, sir. I'll read up about it.
Yeah, because developmental in the developmental assessment, developmental delay is very, very important. Okay, suppose nowadays we put in a standard deviation for everything. We put in a standard deviation. For that 2 standard deviation, 1 standard deviation minus, then only it is called delayed development.
Okay.
Got my point?
Yes.
That's why developmental delay is very important. You should know the definition of developmental delay. Okay, then only you can. If you are using one word, you should know the meaning for that word. Okay.
Yes. Yes.
Okay. Then.
So then we went on to.
Yeah.
We went on to antenatal.
No. Mother of a 4-year, 11-month-old boy came to the complaints of delayed development, which she noticed when the mother was 2 years, when the baby was 2 years old.
Yes.
Correct? No?
Yes.
So, what she was doing up to 2 years?
Sir, she just thought that
the baby.
It'll take some time to grow up.
It takes some time. Why like that? Why they are unable to notice the delayed development up to 2 years? What are the reasons why we have difficulty in diagnosing the CP at 1 year, below 1 year? Below 1 year, whether why she went to you, told he took 1.5 month vaccination, 2.5 month vaccination, 3.5 month vaccination, and he was taken 9-month vaccination also. That time they are not told anything for the mother that your baby is not doing well or anything like that. Only at the age of 2 years she come to know, because she visited. He told she has taken the vaccination, and each time she visited the hospital 1.5 month, 2.5 month, 3.5 months, and 9 months. Whether they are not noticed who gave the vaccination.
Yes, sir. Okay.
Yeah. Tell me.
Sir, I couldn't.
You're not able to visit.
Yes, sir.
Because those things are important. Why?
Okay.
Because the education status of the mother is very, very important here. Because it's the treatment for your CP is multidisciplinary, where everybody is involved. Your parents are involved very much, rather than doctors. Okay, that's why the parent education also you should write. How much is their educational status? That is very, very important in.
Yes, sir. Yes.
You got my point, huh?
Yes, sir.
Okay.
So
next you should know why she was not noticed up to 2 years. That is also the last. Okay. Then what you wrote antenatal history? It is a booked case. What do you mean by booked case?
Sir, she's had at least four antenatal.
Of booked case.
She's had at least 4 antenatal visits.
Yeah, at least 4 antenatal, including 1 registration. 3 antenatal, including 1 registration.
Okay.
First trimester. Okay.
Yes, sir.
Singleton pregnancy. Mother was put on whether it was a spontaneous conception.
Yeah, it was spontaneously conceived. Yes.
That you should write. Whether
Okay.
when she conceived, what is the married life of her, after how many
Okay.
years she married, that is very, very important here.
Okay.
Point. Therefore, when she got married, after how many years of married, because she had 2 abortions.
Yes,
That is
sir.
also very important here.
Yes, sir.
Got my point. That is also very important. We don't know the cause, whether it is a first trimester abortion, second trimester abortion, we don't know that. You got my point?
Yes, sir.
Therefore, you go back. That you have to mention. Because
Okay.
first trimester abortion causes will be different. What are the causes for first trimester abortion? It's
So,
more of genetic.
yes,
Or
sir.
it's more of chromosomal anomalies.
Chromosomal, yes, sir.
If it is second term, it is more of uterine anomalies. Habitual abortions. Okay, that's why
Yes.
that abortion is there means if it is a genetic cause for this CP.
Yes,
Because
sir. Okay.
birth asphyxia may be the second component. Okay, the primary component may be in the prenatal period only.
Okay.
But my point, we don't know.
Yes.
Exactly.
Yes, sir.
That's why whatever you elicit history, each history is very, very important for us. Therefore, it's a singleton pregnancy. Mother was put on iron and folic acid. Why iron in the first trimester you mentioned?
Sir,
we never give iron and folic acid.
You usually start it at 12 weeks, sir, but she told she was on iron.
No, because in the mother had 2 abortion already, definitely wherever if it is a booked case, definitely they'll advise folic acid supplementation before the pregnancy.
Yes, sir.
Okay, we won't give iron and folic acid together at the first trimester. We give only the folic acid. Only in the second trimester onward, we start with iron and calcium and the folic acid. Got my point? Folic acid, we continue.
Okay.
And you mentioned no history of consumption of teratogenic drugs, exposure to ionizing radiation. Any other thing you want to elicit here in the first trimester? Which is teratogenic and the eruptive fevers.
Yes, sir.
Ultrasound scan was done at 11 weeks, showed no abnormalities. What you are going to see at 11 weeks?
Sir, it's the NTNB scan, that nuchal translucency and nasal bone.
So you are going to give 2 doses of tetanus vaccine in the first trimester only?
No, sir. Actually, 1 dose was given, and in the next trimester, the second dose was given.
Okay, because you see, she had this is a Gravida 3.
Yes,
no? Gravida 3.
Yes,
no?
Sir.
Previously, when abortion was at what weeks? 12 weeks, or that time abortion was 16 weeks.
Oh, I should have asked, sir.
Because whether she has taken, what was the gap between the first one and second one? What was the gap between the second one and third one? That is very, very important.
Okay.
The interval period between the each pregnancy is very important. Shorter the interval, more will be the risk factors. Okay.
Okay.
Quickening was felt around 18 weeks. Continued iron and calcium supplement. No history suggestive of fever. Usually, eruptive fevers will not cause much issues in the second trimester. It is more in the first trimester.
First
trimester. To load intrauterine infection. Even teratogenic drugs. Along with that, teratogenic drugs, your alcohol, smoking, all those things.
Yes, sir. Yes.
Even, since it is a booked case, they are regularly visiting the hospital. That's okay. No history of suggestive eruptive fever, maternal anemia, malnutrition, gestational diabetes, hypertension, thyroid. Okay, intrauterine. Urinary tract infections are quite common in the second trimester. Intrauterine infection. If you are writing
third trimester,
you should not write in the second trimester.
Okay.
Intrauterine and urinary tract infections. Anomaly scan showed no abnormalities. Okay.
Yes.
Next slide. Third trimester, mother continued to appreciate the fetal movement. No history suggestive of gestational diabetes, hypertension, everything was there. Mother received regular supervised. That time they have not done any scans. In the third trimester, they have not done any scan, only anomaly scan. Since
no, I forgotten to write it, sir. It was done and she told. All scans were normal is what she told.
Yeah, because all scans are normal because each scan shows significant.
Yes, sir. Yes,
because
sir.
Sometimes what happens if you don't know the presentations. If it is some presentation, if it is a breech presentation, or if it is a shoulder presentation, some other presentations, definitely they'll have difficulty in extraction.
Birth trauma, yes, sir.
And the amount of liquor is also very important.
Yes.
Because liquor is very low, definitely the baby will have distress, intrauterine distress only. That's why each and everything, whatever you mentioned, there is on the flow, umbilical artery flow. That is also very, very important. Yes. All those things we tried to roll out the intrauterine hypoxias. Whether the baby had any intrauterine hypoxia. And very important is leaking PV. You are not mentioned anywhere about leaking PV. Whether usually the mother comes to hospital, how she comes to the hospital, for what purpose? Whether after the pain, whether after the leaking. Because chorioamnionitis, that is PROM. Definitely, this infection they are going to have a damage to your brain, fetal brain. That's why the history of chorioamnionitis is very, very important in third trimester. PROM. That's why whether the mother comes to the hospital, that's why here what happened, even assisted reproductive techniques are also more prone for getting the CPs.
Yes.
That's why whether it is spontaneous conception, all those things are very important.
Yes.
And whether leaking PV, that is also very important, because PROM, chorioamnionitis, everything you should rule out. Okay. Now, if you come to the birth history, you wrote full term baby boy. What do you mean by full term? According to you?
Sir, at 40 weeks, 37 to 40 weeks is term.
Oh, no, 37 to 40 weeks only it is called term. No, 37 to
42
weeks. It
yes.
is called term baby. What do you mean by full term?
At 40 weeks, I think it's 40 plus 0 weeks.
No. What do you mean by early term? What do you mean by full term? What do you mean by late term? Then you have not mentioned about the expected date of delivery. When was the expected date? They may not remember. You can ask if they are given delivery date when the baby got delivered, within 10 days, within 5 days, like that. You have asked that one. That is also very important.
Yes, sir. Okay.
Because if it is a full term baby, the complication will be different. If it is late term baby, post term baby,
post-term, yes. Syndromic
those things are different. You got my point?
Yes.
Therefore, post-dated babies, they'll have other issues. Okay, post-term babies, they'll have other issues. Okay, pre-term baby, they'll have other issues. If you are using full term, you should know the meaning of full term. It is the 39-40 weeks. Okay, 37-38 weeks will be early term. Anything above 41 to 42 will be late term. Anything above 42, it is post-term.
Post-dated.
So post-dated is different. Post-dated is other than the EDD. After the EDD, if the baby born, that is post-dated. After 42 weeks, if the baby born, it is post-term. Got my point?
Yes.
Your full term, if you means, you should know the EDD, because you should know the exact gestation age of the baby. Gestation age of the baby by either by LMP or by ultrasound or by examination. Examination is very difficult now after 4.5 years. And the birth weight was 3 kg, which was appropriate for gestation age. What do you mean by appropriate for gestation age?
Sir, anything normal child should be less, more than 2.5 kilograms.
No. Appropriate for gestation age. If you are using the word appropriate for gestation age, means what?
Okay. Sir, it's between, I'm not sure, sir.
Yeah, if it is between 10th centile to 90th centile. If the weight falls between, for that week, if the weight falls between the 10th centile to 90th centile, then it is called appropriate. If it is below 10th centile, it is called small for gestation age. If it is above 90th, it is called large for gestation. Therefore, you should plot. That's why you should know exact week, whether it is baby 38 weeks, 39 weeks, or 40 weeks. For that 40 weeks, if you plot in the weight, whether it falls between the 10th centile or the 90th centile, because that is the appropriate age for appropriate for gestation age. That is very important, because once you plot that one, you'll come to know. Because small for gestation age, complications are different. Small for gestation age, large for gestation age, they have different complications.
Okay.
And here very important is how the delivery was conducted. That is very, very important.
Yes, sir.
Whether it is a spontaneous onset delivery, whether there is any induction was done, if an induction was done, how it was done, what drugs they are used, all those things play an important role in the delivery of the baby. Whether the baby had any stress. Got my point?
Okay.
That's why when the induction was done, how long was the stage of the labor? It is your first stage of the labor and the second stage of the labor. Second stage of the labor is very, very important for us. You got my point?
Yes.
First stage and the second stage, both are important. That you have to mention, especially if the baby didn't cry immediately after birth, means these two stages are very, very important.
Yes.
Whether there is any prolongation of second stage of labor, whether there is a prolongation of first stage of labor, whether the baby had issue at the second stage or the first stage. Okay.
Right. Yes.
Usually second stage, that we have to know. And you mentioned we have vaginal delivery out of a second, that is not required. Second degree consanguineous, no second, second, what is that? Vaginal delivery out of?
So it's a second degree consanguineous marriage. Not, I can't move. I don't have access to the PPT.
Okay.
Can someone slide it, please?
It's okay. Because that slide only.
No, the next one.
Next one. This one little bit. Yeah, vaginal delivery out of second degree. That is second degree. That is not required here. Okay, out of the second degree consanguineous marriage and all those things are not required.
Okay.
From this side, immediate postnatal period, baby failed to cry for the first 5 minutes. Okay, baby was not cried for the first 5 minutes, and the baby was shifted, but you don't know what they have done.
Yes, sir.
You don't know what they have done, what resuscitation was done, but baby has not cried for the first 5 minutes. It was shifted to the NICU for further management. Okay, now you are in NICU. Yeah. Next slide, please. Yeah, and you are commenting on day 3 of life. What about day 1 and day 2? What was the thing?
Sir, she just told it put in the ICU, sir, and was being treated.
They was put in the ICU. When was the baby was breastfed? When was the baby was given
Sir,
milk?
It was actually expressed breast milk.
Yeah, when the baby was started on expressed breast milk, because nowhere you are not mentioned about that feeding.
Okay.
Because that is very important. Whether the baby was hemodynamically stable or not, we have to know. Because baby was shifted on the 5 minutes only. After how many days baby was started on feed?
Okay.
Whether they are started, because usually if it is a HIE, that is a hypoxic ischemic encephalopathy. The convulsions will be seen within 24 hours. You are mentioning the day of convulsions on day 3. You come to a point.
Okay.
Then what is the seek? Usually, if birth asphyxia, what is the definition of birth asphyxia? How will you define birth asphyxia? When you call birth asphyxia? An idea? Because their definition is very important. Usually, if it is HIE convulsions are seen on the first day of life.
Okay.
Within 24 hours, usually 99%. That's why was 2 days of what are the event that took place in the first 2 days are very, very important. Whether the baby mother saw the baby in the first 2 days, you have to ask all those things. Whether the first 2 days baby was stable, baby was not doing not on ventilator, nothing was done. Whether the baby was given oxygen, all those things are very important here, because that shows the degree of damage to the brain.
Okay.
How the baby was, because that shows how much is the damage. Whether hypoxia, here the main insert in the cerebral palsy is hypoxia or anoxia. Okay, how degree it was, how much, that will come to know only if you know what they have done resuscitation, how the baby was doing the first 24 hours, 48 hours. And day 3 of life, child had developed abnormal movements of both upper limb and lower limbs. Okay.
Yes,
what type of movements?
Sir,
movements of both.
She wasn't sure. She just told abnormal jerky movements is what she told.
Abnormal jerky movements means what? She saw that whether on day 3 baby was. That's why you should know whether the baby, when the mother saw the baby for the first time. You have to ask. That is also very important. Okay. When the mother saw the baby for the first time, and whether she observed that movements, because child developed abnormal movements on both upper and lower limb, you have mentioned. That you have to ask her, because such events she can't forget. Because they are all very emotional events. Because maybe if they're doing like this, they can't forget those events. Even if it is 10 years also, they can't forget. Okay, those moments. If it is some other like feeding and all those things, they may forget. But those moments they can't forget. That's why you should try to elicit those moments. Because we neonatal seizures, there are so many varieties are there. If it is an abnormal movement, it may be some jitteriness may be there. You got my point?
Okay, sir.
Or it may be a subtle seizures may be there. We have to know whether it is a chloric seizures, whether it is a subtle seizure, whether it is a tonic seizures. We won't get generalized tonic-clonic. That's why abnormal movements of both upper limb and lower limb they are mentioning, whether it is only tonic, whether it is clonic, whether it is subtle, because the etiology for subtle will be different, etiology for clonic will be different, etiology for this one, and how many episodes she had. All those things you try to elicit in the history, because otherwise your history will become incomplete. And was given medication controlled set movements in the medication controlled set movements in the NICU means above movements are controlled.
Yes, sir. Yes, sir.
What medication they give in within how many? Only one movement, only one injection they give, and the movements controlled.
Sorry, I did not ask that, sir.
I
mean, she wasn't sure what drug was given, but
yeah. And one more thing is, you already mentioned that 2 days later the baby was shifted down from NICU to wards and subsequently discharged. Within the shows, baby had not had any significant events in the NICU, because baby was, we don't know when was the baby was given breastfed, and you have mentioned only the baby was shifted to mother side, and because feeding is important, whether the baby was mother is able to handle the baby is very important, because this definitely these babies, if they have a cerebral palsy, they'll have feeding issues. They'll be excessive irritable. You got my point? They're more lethargic. Therefore, you try to analyze, because those things will suggest there is an involvement of the cortex, that is neonatal encephalopathy. Try to elicit the encephalopathy features, neonatal encephalopathy features. Okay.
Yes.
Got my point? You try to elicit those histories, but here you don't have that histories, because feeding history is very important here.
Yes.
You got my point? And the baby behavior is very, very important. How the baby was behaving. You have mentioned only the upper limb and lower limb movements. That's all. Okay.
Yes.
And at 4 months of age, baby had another event of abnormal movements. Here also you should know what type of movements, how long it was. You have mentioned that involving both upper and lower limb. Whether started with tonic, whether it is you have to describe that one. And it's a seizure. If it is seizure, how will you differentiate seizure and pseudo seizure? Because babies will be keep on moving something, so many seizure mimics are there. How will you differentiate seizure and pseudo seizure? How will you elicit that history from the mother?
Not sure.
Not sure, because usually if it is seizure, then definitely they will have a opening of eyes. Eyes will be opened. The pseudo seizure, the eyes will be closed. And definitely they will have a drooling of saliva. Everything will be there.
Yes.
More thing is irritable. They'll be more irritable. You got my point?
Yes.
And usually in babies, you can't expect bowel and bladder incontinency. You got my point?
Sir.
Bowel and bladder incontinency, all those things will be only in the adult.
No
loss of consciousness. What do you mean no loss of consciousness?
Sir, I mean, after that baby did, it had normal spontaneous activity after the event.
Normal spontaneous activity. Because loss of consciousness, there are so many things in the loss of consciousness. Whether the baby may have stupor, whether the baby may have delirium, whether the baby may have coma, lethargy, obtundation, so many things are there. But nothing was there. Within 2 to 3 months, nothing was there. Baby, after 2 to 3 minutes, baby was fine.
Yes, sir. That's what.
Then what type of seizure you are expecting there? And the baby is becoming within 2 to 3 minutes, baby is fine. Then what about feeding? What they have done after that? Because for 4 months, baby at this event, they had 2 episodes per day. 2 episodes per day means how many days?
I think only 1 day.
2 episodes per day? Oh, only 1 day. For that, they went to hospital.
No, sir. They told they didn't go to the hospital.
No medical attention for the above. Only one epi, 2 to 3 minutes. What about feeding? Feeding was good. Then whether it is significant seizure or not significant seizure, we have to analyze. Because only if it is significant, only we are going to treat. If the seizure is not altering your hemodynamic system, if the seizure is only occurring for 1 minute or less than 30 seconds, we don't want to put them in long-term anti-epileptic if it is not disturbing too much. If it is not recurring too much also. And you have mentioned at 4 months. After that, they have not taken any medical attention. Then at 2 years of age, then up to 2 years, he never had convulsions.
No, sir. It has only had only 2 events.
2 events. Then it is significant for us,
Yes, sir. Because it's a it happened again, so recurrent.
When it happened, When it
Sir,
occurred?
first on day 3 of life and then at 4 months of age.
After that, because 4 months to 2 years means 1.5 years, almost 1 year, 8 months. No seizure.
There was no such episodes.
And baby was doing good.
Yes, sir. Only that at 2 years she noticed that the child was weak
Baby,
and wasn't.
no issue with the feeding.
Sir, child was being fed by the mother and I had no regurgitation and all that, sir.
No regurgitation. You asked that history?
Yeah, it's in the next slide, sir.
Okay. At 2 years of age, mother visited the hospital as she noticed that her child was weak and was not growing compared to neighborhood child of the same age. Next slide. At 2 years only. Before that, she was not knowing because her education status is how much? Her education status? Because 2 years is very, very long. No? Usually, nobody will wait up to 2 years. Sir. Yes, maximum 8 months or 1 year. Okay. Automatically 1 year. Because in your motor your developmental assessment, neck holding is only not there.
Neck hold. Yes, sir.
Neck holding only not attained, baby. Got my point?
Yes, sir. Yes, sir.
Then why you asked after that child doesn't smile at his mirror image means what?
Sir, basically that social and adaptive.
Why you ask this history? Child doesn't smile at his mirror image.
Sir,
directly why you went there?
Sir, as part of history about general developmental
why you went? Because you should not go directly to the smile at his mirror image. When you will see mirror play at what age?
Sir, at 9 months.
9 months. You have to wait for 9 months mirror play. 9 months. 6 to 9 months mirror play. Yes, 6 months, 1 month. And why you went directly for 7 months? Why you can't ask the history of neck holding, rolling over? You didn't ask those things.
Sir, I thought I'll add that in developmental history and say what the child can't.
You try to. You are asking some history. There should be meaning. If you ask this history and in developmental history, if you are not asking means no meaning. Okay. Got my point?
Yes, sir. Yes.
What is relevant, you should try to write. Doesn't wave bye-bye when waved at. Because once the child has not developed the smile at the mirror image, once you asked bye-bye, bye-bye is what?
At 9 months of age.
9 months. So what is that bye-bye is? What domain it is?
Sir, it's social and adaptive. Social and adaptive, sir.
What smile is?
It's also the same thing.
Same. You see, smile you have asked is the smile only not developed. Bye-bye when, how can you expect?
Okay.
You got my point. You should think whenever you are writing the smile. If there is skipping of milestones, you are asking, you are expecting skipping of milestones. In which diseases will be get skipping of milestones. You got my point. Whenever you are writing something, you should know that.
Yes.
The child is unable to feed himself. Why you asked?
Sir, it's again the child is again fine motor development, sir.
Feed himself, because fine motor, because you already feed himself mean the child is going to take feed only 1 year, 1.5 year like that. Because you have to ask whether the child was able to feed. First thing.
Okay.
Properly. What my point? You should not go and ask for the 1.5 year history. You try to elicit at 3 months, 5 months. What are the things you have to elicit?
Yes, sir.
Speaks in monosyllables and can't form simple sentences. What is this?
Sir, monosyllable.
You should ask history. Speak in monosyllables and can't form simple sentences means. What does it suggest?
Sir, monosyllables generally develop at 6 months of age, and simple sentences is around 1 or 2 word sentences like at 12 months.
12 months.
10 to 12 months.
Therefore, you have asked speaks in monosyllables. That is in relation to the language you have asked.
Yes, sir.
It's the fine motor you have asked. Mother noticed. Then why you skipped everything and directly went into mother noticed stiffening of all the 4 limbs and find it difficulty to dress the child. Why like that?
Sir, I thought
stiffening of all the 4 limbs. When she noticed?
Sir, at 2 years of age only, sir.
Why 2 years? Why 2 years? She was noticed. No, she was never using diapers. She was never holding the baby. She was never lifting the baby. She was never, because you told the neck holding is not there. If the neck holding is there means she can't hold the baby only. Automatically the baby will fall.
Okay.
Definitely. You are mentioning that stiffening of all the 4 limbs and it find it difficulty to dress the child. I don't think so. It is relevant. Means you are not properly taken the history. Mother noticed the stiffening of all the 4 limbs. When you should know? That is very, very important.
Yes.
Because even putting diaper,
Okay.
got my point, or
Yes, sir.
putting the child in the, well, carrying the child, will definitely know if they have definitely spasticity or some stiffness of the limbs.
Okay.
Whenever you are holding the baby, because 2 years, no, yes, you are told there's a global development delay is there. Your history is not correlating with your this one. Mother notices stiffening of all the four limbs, and find it difficult to dress the child. Means before that she never used to dress the child.
She did, sir.
That time no difficulty. She was like she never had any difficulty. That's why from when that at the age of 2 years only she got this problem. At the age of 2 years.
2 years. Yes, sir.
Not before that one.
Okay.
Before that one, the baby was more of hypotonic or hypotonic or like that.
Okay, sir. Yes.
No, I'm asking whether she
sir, I think
that history, whether stiffening was she was appreciate that stiffness when she appreciated the stiffness.
Sir, it was a leading question, so she just she replied yes to it. So
yes, that's why you should not ask leading questions.
Okay, sir.
Leading questions will lead to so many problems. Okay.
Okay, sir.
You should ask the mother to talk. What he was doing, how he was placed, how he was to sit, how he used to, all those things you should how if you tell stiffening, yes, stiffening was there. Yeah? You should not ask the leading questions.
Yes, sir.
That is very, very wrong. Then history of absence of neck holding and because you see history of absence of neck holding and inability to roll over. Once there is an absence of neck holding, then automatically the roll over will not be there.
Yes, sir.
Point, because the development is always that shows you don't know
has to
loss of development. Point. Without skipping the neck holding, the rollover cannot be there. If the rollover is there previously, the neck holding is not there, means then it is a precocious development. That's very dangerous. Rolling over without neck holding. You got my point?
Yes. Okay.
You're asked in that way, that is okay. But if no neck holding, then definitely there's no rolling over will not be expected. If rolling over occurs before the neck holding, before 3 months, that indicates there's a precocious development. That is very dangerous. Where they have acquired the milestones early. Okay. Sometimes they are acquiring the milestone that is very, very dangerous. They are acquired very early. Okay.
Okay.
No point.
Yes.
No history of early and preference. What do you mean by this? No history of early and preference.
Sir, that is when the child is in infancy, he's not only preferring like say left hand or right hand. He's
no history of early hand preference, and you have mentioned the stiffening of all the four limbs. With all the four limbs stiffening, the baby, if you are giving, what do you mean by early hand preference?
Sir, like
where you call early hand preference?
The child uses only a particular hand to do anything.
When you call at what age will call early hand preference?
Less than 1 year of age, sir.
Less than 1 year, because some book says 18 months, some book says 1 year. What does he suggest early hand preference is there?
Sir, it's suggestive of hemiplegia type of.
Yeah, only one side of the body is involved. Here, telling that it is entire body is involved, therefore there is no history of early hand preference. That is mainly to rule out the hemiplegia. Okay.
Yes, sir.
A weakness here is there in the entire all the limbs.
Yes, sir.
You're correct, in all the limbs. Therefore, no history of early hand preference, mainly to rule out the hemiplegia.
Yes.
That is one-sided weakness. Like when asked, the mother says that the child is unable to move any object from one hand to other. What is that?
Sir, this object transference, sir. Another fine motor skill.
Yeah, why there are so many opposites? We have asked fine motor somewhere. Once again, you have fine motor somewhere. Why so much opposite in your history? No, you should always, whenever you are taking a developmental history, you should make a chart. Okay.
Okay.
You should make a chart and you should write at 3 months this one, at 5 months this one, at 6 months this one, whether the baby has got attained or not. Tick mark like that. In that way, you try to elicit that history. Whether the baby has attained this one, tick mark. If it is attained, at what age it is attained? How much delay is there? Then only it is called developmental delay. If it is more than 25% or more than 1 to 2 standard deviation, then only we call developmental delay.
Okay.
Yes. More than 25% or dissociation is there, or more than 1 to 2 standard deviation for that, then we call. That's why you should make a chart for gross motor, one chart, fine motor, one chart, social, one chart, language, one chart. In chart, all the milestones you mention up to that age, whatever age is there, then you try to put whether the baby has achieved or not. Then after that you write. Here
Yes.
very much opposite. You got my point?
Yes, sir.
It's not proper. You should learn that you should make chart of all those things and you try to take in the developmental history assessment. Okay.
Okay. Yes. Sir.
And you are right. Child cries and withdraws when pinched. What is that? Child cries and withdraws.
Sir, sir, in the CNS history, there's no way we could elicit sensory system. So if it's responding to pinch, sir, like painful
responding to
stimulus.
pinch. Therefore,
Yes,
your sensation is normal.
No, we could assess only pain sensation, not the others.
And the other means what sensation?
Sir, like fine touch, gross touch, and
okay,
2-point
elicit in the
discrimination.
history, fine touch, and all those things.
Yes, you can't.
What questions you want to
Heart
ask?
and temperature changes.
Anything you ask like that? You're not asked.
No. Okay.
You're not asked, I think. If you want to elicit those sensations, if there is a sensation defects are there, if there is sensations or defects are there, where is the lesion? Where
sir, the pre-central gyrus.
Why? Why like that?
Because of sensory cortex, sensory area.
Cortical sensation. Cortical. What are cortical sensations?
Sir, pain, touch, temperature.
No. Cortical sensation. The sensation which are perceived mainly by the cortex. Their cortical sensation. We have cortical sensation like your stereognosis, your graphesthesia, your 2-point discrimination, 2-point localization, all those things. If these cortical lesions are lost, then there is an involvement of your cortex. That's more of cortex involvement.
Okay.
You got my point?
Yes.
Try to because whatever you are eliciting, it should be next slide, please. No history of strabismus, that is abnormal. That shows there is no involvement of, according to you, vision. Vision is normal.
Vision is, yes.
No, vision you are not asked whether the baby is appreciating the movements. You asked, no, you are not asked. Because you are asked only the movements of the eyeballs.
Okay.
But you are not asked about whether the baby can be able to appreciate the movement, whether the baby can recognize the mother, baby can recognize something on the floor, like that.
Okay.
Because the show the vision, because in your cranial nerve assessment in the vision, you have to see all those things.
Yes.
Okay.
Yes.
Because any involvement of cranial nerves are there, cranial nerves involved or not, you have to know.
Yes.
Okay.
Yes.
And collection of food in the mouth. What does this collection of food in the mouth means?
Sir, trigeminal, facial nerve and trigeminal nerve.
Facial nerve or trigeminal nerve? Why facial nerve and trigeminal nerve are involved in your CP? Where is the facial nerve arising from? Where is the trigeminal nerve will be arising from? If there is a collection of food in the mouth, what does it suggest?
Sir, unable to swallow or
swallowing. What is required? Where is the swallowing reflex is situated in the brain? You got my point?
Okay, sir.
If you are asking collection of food, if there is a dysphagia, difficulty in swallowing, and that's why feeding problems. That's why you have to ask the feeding problems. Whether the baby is able to take feed properly, whether the baby is able to latch at the breast properly, whether the baby is able to swallow the food properly, whether they start complementary feed at the properly. All those things are very important here.
Fine.
That rules out the cranial nerves arising from your middle oblongata. Okay, you got my point. 8, 9, 10, 11, all those things. Your tongue movement, 12 also it will be removed. Therefore, that shows there is no involvement of your brainstem. You got my point?
Yes, sir.
Cranial nerves are not involved. That's why no history of facial asymmetry and nasal regurgitation. Nasal regurgitation is mainly for your this one, 9th and 10th.
9th and 10th, yes, sir.
No history of change in voice, no history of bowel or urinary incontinence. Because bowel or urinary incontinence, how can you write here? Because by 4 years, 1 month, then the baby will become dry by day and dry by night.
Okay.
What age?
Not sure, sir.
Not sure, because that is very, very important. No, if you are for a 2-month-old, 2.5-year-old baby, if you ask those questions, it will not be appropriate.
Okay. Yes.
What a point. Yeah. You should know whether the baby is able to tell whether the baby is able to go for urination, whether tell the mother that I am passing urine. Because definitely that baby with so much hypotonia, no neck holding, nothing is there means he won't tell. He will pass it there only.
Okay.
You are not asked the history properly. You want my point?
Fine. Yes.
And Here, you are mainly you are ruling out the cranial nerves, and suddenly
Yes,
now you are asked about the no history of neonatal jaundice.
sir.
Neonatal
Trying to
jaundice
rule out
was
etiology, sir.
now you are asking for etiology.
Yes,
Since
sir.
you have already got the etiology in the form of birth
Birth
asphyxia,
asphyxia.
and you have not taken entire NICU stay. Neonatal jaundice you have asked. What type of CP you will get in a neonatal jaundice?
Sir, basal ganglion, dyskinetic types.
Dyskinetic CP. Dyskinetic CP means what will be the more abnormalities? It is a movement
Postural,
disorders.
most, yes, movement and posture.
Involuntary movements will be more. Your
Yes, sir.
chorea, your dystonia, your
Yes.
acidosis, those things.
Actixia.
Because you
Yes, sir.
never got any involuntary movements you told.
Yes, sir.
Involuntary movements you told, but it is like more of seizure you told.
Seizures.
Not
I
like
was little confused.
tremors, or you're not like your chorea, acidosis, nothing. No involuntary movements. Neonatal jaundice commonly will lead to your kernicterus will be
Connectors,
more
yes,
of
sir.
dyskinetic CP, and the lesion will be in the okay. Postnatal infections, why you ask this one?
Sir,
What
because
postnatal infections?
meningitis and encephalitis can also lead to
Yeah,
cerebral
what
palsy.
type of CP you can get in postnatal infections? If it is meningitis, if it is a encephalitis, what type of infection? Because you never told that there is a baby was discharged within 2 days. That's why
Yes,
you
sir.
won't get a postnatal infection only.
Yes, sir.
That's my point. But that's why you should not repeat, keep on repeating unnecessary things. Because,
Okay.
because in the examination, you are given only 45 minutes. In the 45 minutes, you should finish examination, you should finish history, everything you have to finish. That's why whenever you are going to the exam, you should keep on examining the patient. While examining the patient only, you should keep on asking the history.
Okay.
First thing is you should complete the examination. And during that examination only, you should keep on asking the histories. Okay.
Yes,
At
sir.
a time,
Yes.
you should do both, and within 20 minutes, you should finish everything. And after 20 minutes, 30 minutes, you should write for another 15 minutes. Because if you keep on taking only history, then it will take 45 minutes or 1 hour. Sometime one day also it may take. That's why you should
Okay,
know what to write and how to write all those things. You should keep on practicing. It's all depends upon your presenting complaints.
yes, sir.
It all depends upon your presenting complaints. You can't write unnecessary things. If you're there, no involvement of cranial nerves. Like that. Simple word.
Okay.
If you are
Okay, sir.
involved is there, which cranial nerve is involved? That is specific. If you are suspecting, like
Yes,
that.
sir.
No need to mention everything because you don't have
Okay.
enough time to do all the things. Okay, got my point?
Yes, sir. Yes, sir.
And
Yes, sir.
no history of fall from height or head injury. That is injury you are asked because no history of loose stool or constipation. Why you ask this loose stool or constipation?
Sir, it is one of the complications of cerebral palsy. There'll be constipation in the child.
Constipation is important. Loose stool is a complication of no. Loose stool is not complication.
Yeah. Okay. Sir, diarrhea in childhood.
Diarrhea as a diarrhea leading to dehydration. Dehydration leading to this one. This one. Well, in which age group you ask this one loose stool? Any like from the past 4 years, they remember that one. Every baby will have loose stools. You got my point.
Okay.
Every baby will have
Yes,
loose
sir.
stools. Whether that loose stool is, you got my point.
Yes, sir. Yes,
If
understood.
there are constipation, it's one of the comorbidity of the your
Yes, sir. Cerebral.
cerebral palsy. Constipation, your regurgitation, vomiting, feeding issues. If they
Yes.
ask all those things, then it will be more. Okay.
Okay.
That's
Yes.
right. If you're writing something, you should know. Next time, you should modify all those things. Okay.
Yes, sir.
And
Yes.
no history of recurrent respiratory tract infections. What do you
Yes,
mean
sir.
by the definition of recurrent respiratory tract infection?
Sir, more than 2 hospitalizations in a year
More
for
than 2
pneumonia.
hospitalization in a year. More than
For
2
pneumonia.
Yeah, because you have mentioned recurrent respiratory tract infection means either it may be upper respiratory tract infection or lower respiratory tract infection.
Lower. Okay.
If you are mentioning pneumonia means it is lower respiratory tract infection.
Okay.
You call
Yes,
recurrent infection if it is 2 or more.
yes, sir. 2 or more hospitalizations because of the pneumonia.
That's all. That is recurrent pneumonia.
Or 3 total
Recurrent pneumonia is
infections.
different. Recurrent pneumonia is different. Recurrent respiratory tract infection is different. Recurrent pneumonia we call if it is more than two pneumonias in a year or any time more than 3.
More than 3. Yes.
More than 3 will be called will be called recurrent pneumonia. Recurrent pneumonia is different. Persistent pneumonia is different. Recurrent respiratory tract infection is different.
Okay. Yes.
When you call recurrent respiratory tract infection, how many in a year you should get? How much that should be? Suppose I'm getting a cold, cough, or rhinitis. Within 1 day, I'm fine. I like that I'm getting every month. You will take that is a recurrent respiratory tract infection and it is significant. When you call that significant recurrent respiratory tract infection, why you are asking this history?
Sir, I'm not sure about. I think it's 6 episodes. I'm not
6
sure.
episodes. How 6 episodes? 6 episodes lasting for 1 day, lasting for
No,
2
sir.
days.
In a year, in a year.
Yeah, in a year 6 episodes, more than 6 episodes, but it should be distressed. Means distress
Okay.
means it should be a more of stress to the this one. It should be like absence from the school. You got my point?
Yes, sir.
Day-to-day activities will be abnormal during that time, because if I am cold, I am walking here and there, nothing running on everywhere. Not an
Yes, sir.
it's not a significant, but it
Yes,
should be
sir.
significant one.
Okay.
Okay, you should know it should be significant one. Then that is the definition for recurrent respiratory tract infection. You got my point?
Yes, sir. Yes, sir.
It should be more than 6 episodes and it should be a significant one.
Yes,
You
sir.
got my point?
Yes, sir.
Therefore, then previous slide, you go to previous slide. Then why you have mentioned no history of bluish discoloration of lips or extremities?
Sir, any again any cyanosis or any congenital heart disease the child has?
More no kind. How congenital heart disease and your CP is related?
So some syndromic child.
Some syndromic child. You're not expecting any syndromic child, no? You're expecting syndromic child here. You're not expecting, no? If you're expecting those syndromic child, you try to rule out those things. You are not expecting. That's why your history, you should remove those things. You're unnecessary. You are only digging your own grave.
Yes, sir. Yes.
Got my point. Unnecessary, yes, you should remove. What is necessary, what is relevant here, you should narrow your path. You should not widen your path. If you go to widen, then you'll be stuck. Okay.
Yes.
Next family chart. Next slide. Because here in your history, I told you, no, where you have to get your motor system evaluation, everything. You have to evaluate the higher mental function. You have to evaluate the kernel of involvement. All the whatever examination you are doing, those things you get in the histories.
Yes.
Okay. Then your examination will be very easy.
Okay.
You come to know that in the cranial nerves, this cranial nerve is affected. This cranial nerve. Then while examining that, you look for those. You got my point?
Yes.
Only you try to get the motor system assessment, cranial nerve system examination, your cerebral system examination, everything. Any coordination issues will be there. All those things.
Okay.
You try to get those things. Depend relevant on your cases. Okay.
Yes.
And try to get the etiology for this.
Etiology
for this, and how much it is going to impair, that is functional impairment.
Functional.
Whether the baby is able to do any activities. For 4.5 months, baby is able to do dressing, undressing, all those things. How much impaired? Whether the baby is completely dependent on the mother. Because definitely, because with all developmental this one, definitely the baby is, those things very important. Because I told you in a CP you should get the anatomy, you should get the physiology, you should get the,
functional issues
functional and the etiology. All those things
sir.
you should get, and the comorbidities. Then your things will be very easy. You got my point?
Yes.
Then in the family history pedigree chart, it is a 2nd degree consanguineous marriage that shows some, and there is a first 2 abortions. You have to
abortions.
take in detail history about the abortions.
Okay.
What age abortion?
Yes, sir.
Second trimester, whether like that. All those things are very important. And you have asked no history of convulsions in any family members. Why this history you asked?
Sir, any child has because he has 2 recurrent episodes of seizures. There's history of any familial epilepsy like that.
Familial epilepsies, because that was not a persisting, no. That is only you are told at birth 2 episodes. I'm not worried about the conversions, because at the 4 month also baby had only 2 episodes, and then they never took any treatment, and the baby was not started any treatment. Then it is not significant for us.
Okay.
Why specifically asked conversion? That's why I'm asking. Okay, next slide. Nutrition history.
Sir, it's
Developmental
after.
history. Yeah,
Yes,
developmental history you mentioned, no?
yes, sir.
Last motor, no neck holding only is not there.
Yes, sir.
Therefore, developmental quotient will be in that. Fine motor.
Sir, he has child has a pincer grasp, but it was developed at 4 years.
Child is how will you elicit the pincer grasp?
Sir, you can hand something to the child. If he's able to hold the tip of his thumb and index finger, then it's a mature pincer grasp.
What happened? What you are going to give?
A paper or any object or a pen.
Okay. Now you are able to you gave the paper. Baby is able to you ask the mother what you gave and how the baby was holding. The baby is holding with what? Whether the baby is holding the entire thumb, entire fist, or
no, sir, with the tip of the thumb. Tip of the finger.
Of the thumb and the finger.
Yes, sir.
The tip of the thumb and the pincer grasp. When the baby was achieved that one? At
4 years. 4 years, sir.
At 4 years. Unidextrous reach at 10 months.
10 months.
Bidextrous reach at 8 months. That is appropriate because why it was waited up to almost 3 years. Bidextrous, whether you elicited the history properly. Bidextrous reach means what?
Sir, he pushes both the hands towards an object to hold it.
That one, approximately they told 8 months.
Yes, sir, approximately.
Okay. Then social and adaptive. Social smile at 1.5 years. Recognizes mothers at 2 years. Then after that?
So that's it. After that, he's not achieved any other.
Okay. It's according to the social developmental history, the baby is only like 3 months.
3. Okay. 3 yes, months. Sir.
According to your fine motor, the baby is only 9 months.
Yes, sir.
9 months. And gross motor, the baby is only 3 months.
3 months.
Okay. Then language, the baby is only 8 months. Monosyllabus.
Yes, sir. Only monosyllabus.
6 months. 6 months.
6 months.
Because bisyllabus you are not mentioned.
No,
not
sir.
Speaking 2 syllabus means bisyllabus.
Bisyllabus.
Never attained. Okay. What do you mean by global developmental delay? Therefore, it's one of the cause for the global development. What do you mean by the definition of global developmental
delay? Sir, global developmental delay is when the developmental quotient is less than 70% in 2 domains of the 4.
In 2 more domains. What are the 2 domains here? In your gross motor, fine motor, 2 domains, that's sufficient?
Oh, sir, I'm not sure, sir.
Not
any
sure.
2 domains?
Any 2 domains. What do you mean? Any 2 domains mean? No, you're wrong.
Okay, sir.
When you call global developmental delay, we take only 3 components, only 3 domains. We take gross motor and fine motor together. That is motor domain, then social domain, then language domain. In that thing, we take 2 or more domains.
Okay, sir.
Delay in 2 or more domains. Okay, in that it's called global developmental delay. Therefore, even though you have 4 domains, gross motor, fine motor, social, and language, when you define the global developmental delay, we take only 3 domains.
3 domains. Okay, sir.
Therefore, anything more than 2, delay in 2 or more, okay, will be called global development. Therefore, we take only 3. You should remember that gross motor and fine motor will be taken together, and social and language will be separate. Therefore, totally 3. Therefore, anything more than 2, 2 and more than 2 will be called, global development. What is development regression?
Sir, the child has attained certain milestones, and as time passes, he's losing certain abilities.
Okay, losing. That is when the child loses previously acquired skills.
Previously acquired,
developmental, yes. Because one of the differential diagnosis for your cerebral palsy is neuroregression syndromes.
Yes, sir.
That's why you should, whether the baby had acquired those skills and to forget, then developmental. What do you mean by development dissociation?
Sir, I don't know, sir.
Okay, it's okay. But here, global developmental delay, you should know what is the definition for global developmental delay, and you should know what are the causes for global developmental delay. Because all global developmental delay will not be fit into CPs. We have specific causes also. You should know those causes. You got my point?
Yes.
In your history, you try to search for those causes. If the baby is having global developmental delay, other than CP, what causes we can suspect? Because the individual etiology for CP will be those causes with specific etiologies, like your Down syndrome, like that. You got my point?
Yes.
Those things you try to elicit. Next. Next slide, please.
Sir, immunization.
Dietary history. You have mentioned that what is the requirement for this age group?
Sir, about 1400 kilocal per day.
1400 kilocalories. Baby was getting only 80 kilocalories.
880 kilocalories.
What about feeding? Whether the baby was the mother is able, mother was feeding the baby, or baby was
yes,
taking?
Sir. No, sir. Only the mother is feeding the child.
Mother is feeding. Totally, mother is feeding the baby.
He's fully dependent.
What food mother is giving? All the homemade food.
Yes, sir. Homemade table food, whatever the family is eating.
Here in dietary history, breastfeeding, complementary feeding, all those things are very important, because definitely CP will have a malnutrition. Okay, malnutrition, yes, maybe it may be undernutrition, overnutrition. Some babies they'll have obesity issues. Some babies will have a undernutrition issues. That's why it's very important in a CP case to elicit a nutrition history. Yes. In a particularly from, because here breastfeeding, complementary feeding, everything only 24, because definitely the baby will be having a failure to thrive features. Whether one of the comorbidities of your CP is failure to thrive. Therefore, whether the failure to thrive is only the nutritional impact, or whether the disease sequelae is causing the failure to thrive, all those things you try to get. If the nutrition is adequate, that shows it's the disease only.
Yes, sir. Yes,
that's why we have to know whether you calculate the calories for that weight or for that age of the weight.
Sir, we calculate for age, what the appropriate weight for that age we calculate.
That age, not for that.
Not for the child's age. Yes, sir. Not child's weight.
Not child's weight. Not for age. That's up.
No, sir. We calculate for weight that is expected in a child of that age.
That age, not for that weight. Not for that weight.
Not for the baby's current weight.
Why? Suppose if
because he's already
for
in
the
deficit.
baby's current weight, how much is the calories you are getting? How much protein deficient you are getting? How much calories you are getting? Protein is not deficient, only calories deficient.
Yes, sir.
It is possible.
Sir, it's.
It is possible. This is not possible.
It's not.
Then how you wrote all these things?
No.
2 grams, 2 grams, and calories not getting means there is a problem. Definitely, there is a problem in your dietary history. You know, yes. I'm asking because if your baby is unable to get adequate calorie, means that definitely the protein will be automatically will be low. You may get more calories but less protein. Point. Or calorie less protein is high means it's very not appropriate.
Okay.
There is a problem in your dietary history. Okay, you try to modify that one. You should use your sense that what may be the things. But because whenever you calculate, we required for that age and as well as the baby's weight also, because we don't know exactly.
Okay.
Point. Next slide. Dietary history. There are some.
Sir, we calculate for both, sir. Both, weight of the current weight of the child and
calculate both. That is very important because some school says it is more for that age. Some schools care for that appropriate age. Okay. But better to calculate for both and you see whether any difference is there or not.
Okay.
Because we can't expect the baby 5 kg baby to eat 10 kg baby's food. You got my point? Because in a malnourished child or a CP child, the baby weight may be only 5 kg. You got my point by 1 year.
Yeah.
But normal weight that age will be 10 years. 10 kg we expect. Average weight. Therefore, 10 kg food we can't give to that baby.
Correct.
You got my point? If you are causing protein overload. That's why for that age, that's why different schools will have different thoughts, but you should use your sense.
Okay.
Whether I can do like that. Baby weight is if it is a PM case at the age of 1 year, maybe baby weight is maybe 5 kgs. For that age, we expect 10 kgs, 9 to 10
yes,
kgs.
Sir.
You got my point? We can't load them too much.
Okay.
For that age, there are so many controversies are there. That's okay. Next slide, please. Next slide. Next slide. Hello. Yeah, next slide, please. Then you ask socioeconomic history.
Yes, sir.
Yeah.
So socioeconomic history, the only thing that was only pertinent positive finding was There's only overcrowding that was present in the home.
Why
And no
socioeconomic history?
environmental.
You ask socioeconomic history in relation to CP. That is very important.
Yes, sir.
Why?
Sir, again, sir, it is depends on education of the parents. Because if the parents are they're unable to identify signs preemptively, then they'll present to the hospital a little late. And
Okay. Because one of the risk factor for your CP is poor socioeconomic status. Okay. Poor socioeconomic status is one of the risk factors. That's why
yes,
socioeconomic status and where they live, education status, all those things are important. Because
yes,
how much caring of the baby, that is all those things are important. That's why
yes,
whether they are able to go for all those therapies, all those things are needed. Okay.
yes,
Come to the examination part now. Because in your history, you should summarize all those things. Your history
yes,
is not appropriate because since you are in a fourth term, you can learn so many things by repeatedly doing the mistakes. By repeatedly doing the mistakes, you can learn so many things. Now you go to examination part.
Yes, okay.
Those things in a summary, you should get all those things and you should confirm those things in your history. Examination. Yes. Okay. Now examination. Okay.
Sir, a 4-year, 11-month-old boy child who appears pink is breathing comfortably.
Pink. No. Finish. Will finish. Appears pink means what? Is what? Fair, very fair. Pink means
no, sir. Like he's not cyanotic. Basically, he's breathing comfortably.
Pink. We can't appears pink. Okay.
And was breathing comfortably and was examined in supine position.
Okay.
And his vitals were temperature is 98.4 degree Fahrenheit. Pulse rate is 66 beats per minute. It is normal in rate, rhythm, character. All peripheral pulses are felt, and there was no radioradial or radiofemoral delay.
No, 66 beats per minute is normal for that 4.5 years age group.
Sir, no, it's a little less. It should be 95 to 110.
Then now on the 65 normal rate you have mentioned, rhythm you have mentioned, character, all peripheral pulses felt, no radioradial delay. Okay, that's right.
Rate is a little less.
Yeah.
So, rate is less.
Beats in which artery you check the beats?
Sir, radial pulse for normal rate. Then for rhythm, character, I check the carotids and carotid pulses.
For volume?
Carotid pulse.
Why volume you have to check for carotid? No, I don't agree with carotid volume because all the volume is more in the carotid. What do you appreciate volume in the carotid? You can't appreciate the volume in the carotid. You should always go for the radial pulse. Only for character, you can go for the carotid. Only for volume, it's better to go with the peripheral pulses. You can appreciate volume better in the peripheral pulses, not in the carotid. Carotid is only for the character. Okay.
Yes, sir.
Then respiratory rate.
Respiratory rate is 24 breaths per minute.
Is it normal?
Yes, sir. For that age, it's normal.
Normal. Okay.
And blood pressure is 96/64 millimeters of mercury.
That is normal for your pulse rate and BP is correlating?
No, sir.
No.
Pulse rate is a little less, but BP seems to be normal.
Why the rate is less? What is the reason for the low? Whether you are not checked properly or BP is having any issues?
I'm not sure, but it was 66 beats per minute. We checked.
Okay.
Yes, sir.
Next slide, please.
Sir, anthropometry.
Yeah, anthropometry. Next slide. Yeah.
So the height of the child is 67 centimeters and the expected height is 107 centimeters. Height for age is 63% and inference is it's less than third centile and this is third degree stunting.
Weight of the third centile only, how you mentioned that the third degree centile stunting?
Sir, it's that Wellcome Trust classification.
Oh, Wellcome Trust classification, yeah. Okay.
Because stunting and wasting is there, so.
Because one thing you mentioned standard deviation. For one thing you mentioned third centile. Why WHO growth chart of standard deviation?
Sir, for weight I used WHO charts. For height I used the IAP and the WHO combined charts.
Okay, WHO, in the WHO, what are the centines they have given in the WHO chart?
So just
no, you have the WHO chart with you?
Yes, sir. I have it with me.
Yeah. What are the
Sir,
sentence?
for height, sir.
Huh?
For height, is it?
For height or weight, anything. What are the
Sir,
sentence they are given?
For height, it is 3rd, 10th, 25th, 50th, 75, 90, and 97 centile.
97 centile. For weight, also same thing.
Yes, sir. Height and weight, same thing.
Same
Third,
thing.
yeah.
Here it is less than 3rd centile. You have mentioned it is 3rd degree stenting. Okay.
Yes, sir.
And weight, you have mentioned severe wasting.
Yes, sir.
Wasting.
Yes,
Wasting is you mentioned by weight.
Sir, it's
height by weight, or you mentioned
weight for height, sir. Weight for height.
By height. Why you have mentioned for weight only? You have mentioned severe wasting.
No, sir. In that inference column, I've written that.
Inference column, you can't use that severe wasting in the weight column. You got my point. Wasting, if you are using the word wasting, it is more in relation to the weight for height.
Okay, sir.
You got my point?
Yes, sir.
If you are using stenting, it is height. For weight, what you will use? If you are using you got my point. If you are using wasting, it is for mainly you use for height or weight.
Weight for height. Yes.
No, weight for height. Sorry, weight for height. Not for your only weight.
Underweight. Sir.
Underweight. Like that, you should use those words, underweight.
Okay.
Not wasting. Wasting is only for weight for
height.
That's why you should mention the weight for height. If it is a weight for height is less than 3 standard deviation. What does it suggest?
Yes, sir. Severe wasting.
Severe wasting. What is that? Severe wasting is?
Sir, in that
severe acute malnutrition.
Yes.
Severe acute malnutrition. That is severe acute. One of the diagnostic for severe acute malnutrition is your weight for height is less than 3 standard deviation. One of the severe malnutrition, that is.
Yes, sir.
Okay, acute severe malnutrition.
Yeah.
What about mid-arm circumference?
Sir, it's 12 centimeters, sir.
12 centimeter. Then you have mentioned wasting scene. What is that inference? Wasting scene? You have
sir, because normal mid-upper arm circumference should be greater than 13.5.
13.5, but here 12 centimeter. I don't believe that it is 12 centimeter. It is less than 11.5 centimeter, I think. 12 centimeter is not normal. It is borderline.
Yes, sir.
Therefore, when you are going to define severe acute malnutrition based on mid-arm circumference,
mid-arm is less than 11.5 centimeters.
Most probably, I am thinking it is 11.5 or 11 centimeters because weight is so much less. Your mid-arm circumference, definitely it will be less only. You are not checked properly. Definitely, there is a problem with your mid-arm upper arm circumference because your mid-arm circumference is normal, but weight is less. Means what does it suggest? What is the importance of mid upper arm circumference?
Sir, it's nutritional bulk of the muscle and nutritional status.
No. What is the importance means when you are going to measure the mid upper arm circumference at what age?
Sir, under 5 years of.
No, you won't measure after 5 years.
So then
you can measure after 5 years, 10 years also you can measure, but very important is between 1 to 5 years.
1 to 5 years.
Why 1 to 5 years is very important? Mid upper arm circumference.
Don't know.
Because the mid arm circumference remains constant during 1 to 5 years. You got my point?
Okay.
It is mid arm circumference. That's why it's very easy to. Because if the values keep on changing, nobody will remember. That's why even I ask if you tell that much, because 1 to 5 years the mid arm circumference remains constant. It is more than 13.5 centimeter. That's why if you give some tape, if it is less than this much, that is for 5 years, no issues, no remembrance. Only one value, if you remember, that is sufficient. Suppose if your weight means for this 5 months, we expect 6 kgs, 1 year we expect 10 kgs, for 2 years, 12 kgs. You have to remember. For mid-arm circumference, it is always constant. That's why it is one of the easiest way to assess the child. Even the layman can assess. Only if they do properly the mid-arm circumference. Only you have to teach how to do the mid-arm circumference. If you teach them properly, if they assess, then it's very easy to 1 to 5 years. It is constant. Why it is constant? Why the mid-arm circumference? Because the child will be growing. Because at 1 year, the child is 10 kg. You got my point? But 4 years, 5 years, the baby will be 15, 17 kgs. If the baby is growing means your upper arm circumference should grow, no?
Yes.
But why it is constant?
Don't know, sir.
Why it is constant means because your fat is going to be replaced by your muscle mass.
Okay.
Okay, therefore the
Yes,
circumference remains same. Your fat is going to be replaced by muscle mass. If there is no muscle mass, if there is no protein, the fat only is going to last.
Okay, sir.
Therefore it is going to be decreased.
Decreased. Okay.
No muscle mass.
Okay.
Therefore
Yes,
fat is going to be replaced by the muscle mass. Fat is going to be replaced by the muscle mass. Therefore the fat is going to be replaced by the muscle mass means then your muscle mass is going to develop. That's why the protein is good. If the muscle mass is not coming but fat is going means your mid-arm circumference will be decreased.
Yes,
yeah,
sir.
one more point. That's why that is the mid-arm circumference significant. There is some problem with your mid-arm circumference. Just check it.
Yes, sir.
There is a grade for malnutrition. Here in the malnutrition, you should mention whether it is acute malnutrition or a moderate, acute severe malnutrition or a MAM, moderate acute malnutrition.
Yes, sir.
This shows it's more of acute malnutrition.
Okay, sir.
Severe acute malnutrition. SAM.
Yes, sir.
Yeah. According to some mid-arm circumference, some error is there. You check once.
Yes, sir.
Yeah, you should not mention wasting. Wasting, you don't use the word for mid-arm circumference.
Okay. Yes.
Tell it abnormal, normal, like that. Borderline.
Yes, sir.
That much you can inference. And head circumference. Head circumference 40 centimeters there.
Yes, sir.
This when you are going to define microcephaly.
Sir, when head circumference is less than 3 standard deviations.
How to define macrocephaly?
More than +2 standard deviations.
Yeah, for macrocephaly we use 2 standard deviation.
Yes.
For microcephaly we use 3 standard deviation. That you have to remember. Okay.
Yes, sir.
3 standard deviation. Therefore, head circumference also you have to use the WHO growth chart.
WHO, yes. Sir.
Standard deviation is there less than 3 standard deviation. Sometimes you have to use the 2 standard deviation also sometimes.
Okay.
But 40 centimeter. At what age we expect 40 centimeter?
Sir, at 40 centimeters, it's around 3 to 6 months of age.
Why that much gap? 3 to 6 months. Why that much? 3 to 6 months?
No, sir, the child grows. Head circumference grows 2 centimeters first 3 months of life.
Yeah, therefore, at the age of birth, how much you expect the head circumference?
It around 34 to 35 centimeters.
How much? 30 to 34?
No, 34 to 35.
How much? 34 to
35.
Yeah, usually around 33 to 35. Sometimes we can go up to 37 also. Sometimes if the baby is big. Therefore, from that time, if you expect every 2 centimeters per month, by 3 months, the baby should be 40 centimeters.
40 centimeters, yes, sir.
Yeah, by 3 months, the baby should be around 40 centimeters. If you expect 2 centimeters, the child is around 35. If you take, okay,
yes,
every 2 centimeters, 34 to 35. Therefore, 3 months. Therefore, according to your head circumference, the baby is 3 month old baby.
Yes, sir.
Okay. And to your weight, the baby will be around 9 months. Okay, 1 year.
1 year.
And your height, the baby will be your height age will be around 67 centimeter. When you expect a 67 centimeter?
Sir, at birth it's around 50 and it grows around 1.5 centimeters for the first 3 months.
No, not 1.5 centimeter. No, 3.5 centimeter per
3.5,
month.
yes, sir.
3.5 centimeter for first 3 months.
Then it's 2 centimeters for the next 3.
Okay.
Then 1 centimeter, 1.5.
Therefore, how much you expect at 1 year? 1 year
11,
we expect 75 centimeters. 25 centimeters in the first year, okay. 12.5 centimeters in the second year, 10 centimeters in the third year, and the fourth year it is around 8 centimeters. Thereafterwards, every year 5 to 6 centimeters. Okay. Yes, therefore, here 67 centimeters there means the baby will be approximately around 7 to 8 months. Okay, yes, height age will be. Therefore, here everything is decreased.
Yes,
okay?
Sir.
It does shows a chronic disease.
Yes, sir.
Chronic disease. Okay. Next, because your stunting is there, height is affected, weight is affected, everything is affected. It's a chronic disease with acute and chronic, acute severe malnutrition. Everything is there. Next.
Yes, sir.
That's why inference you should mention properly. There is some wrong in your inference. Whenever you are using the what chart, that is important. Whether better to put that chart. Okay, better to put that chart, and in that chart, if you have a circle and if you show, that will be more appropriate.
Okay.
That will be more appropriate. Next. Next slide, please.
So next is head to toe examination.
Yeah, show me the next. Can you move the next slide? Yeah, head to toe examination.
So the head appears small in size, but
Okay.
normal in shape. The anterior and posterior fontanelles are closed. Hair appears normal. There is a broad nasal bridge.
Posterior fontanelle will be opened up to 4 years.
No, sir, it's closed.
No, it's closed. No, it will be
Yes.
opened.
No, sir, it won't.
Air appeared normal. Why air appeared normal?
Sir, in case
so
of
much malnutrition is there.
Yes, it
Baby
should
is
be
not receiving this one. Definitely there will be abnormalities in the air.
Yes, sir.
If your air is normal, means the baby is getting adequate protein, adequate calories.
Okay.
Definitely the air will be lustrous. The air may be very fragile. All those things. Definitely there is so much. Air growth may be less.
Okay.
There is some issue with your air appeared normal. Okay.
Sir, there was a broad nasal bridge that was seen.
How you are going to define the broad nasal bridge? In what way you define the broad nasal bridge?
Sir, I don't know if there's an objective measurement, but on subjective, I think I just saw it.
Measurements are there to define the broad nasal bridge. That's why I'm asking. Because if you're using any word, you should know meaning, how you define that one. Because we can't define like that. Some people will tell yes, some people tell no. But that's why there are some measurements are there. If you measure that measurement, if it is that one showing that one, then it's hypertelorism or hypotelorism, everything you can come to know.
Okay. Yes.
That's why if you're using one word, you should be knowing broad nasal bridge. How you what is the measurement between the inner canthal and outer canthal? How much?
Okay.
All those things.
Okay. So then oral cavity, there was a high arched palate that was seen.
Okay.
The ears appeared large. The neck, chest, and abdomen.
In this, suppose broad nasal bridge, high arched palate, ears appeared large. You got any facial dysmorphism here?
Yes, sir.
Yeah, what type of facial dysmorphism? It fit into any facial dysmorphism? You can tell facial dysmorphism in the form of broad nasal bridge with high arched palate. The ears are large. Large means what according to you? Whether the back ear was there, whether there is so many deformities are the ear are there. In what way it is large?
Okay.
And compared to the head.
Compared to the head, it was large.
And any low set ear was there?
No, sir. No low set ear.
Low airline neck is there. Airlines. You appreciate the ears, backside ears. Any low air neckline?
No, sir.
No. Okay. All those things are important. If it is some syndromic child, they'll have some difficult, typical facial dysmorphism.
Okay. Yes. So the extremities and external genitalia appeared normal. The back and spine was also normal, and skin appears normal.
Why back and spine are normal? Skin appears normal.
Sir, skin appears normal.
Everything is normal. Yeah.
Sir?
Tell me.
Sir, the skin. Back and spine, the child could have scoliosis and.
Just right. Spine normal. No, nothing was there. No scoliosis.
No, sir. No normal. And skin is to see for any neurocutaneous markers.
So what neurocutaneous markers and what neurocutaneous markers you are suspecting in relation to CP? Which CP will have neurocutaneous markers? Your neurofibromatosis will have a CP? No.
I don't
Which
know.
neurocutaneous syndrome you are suspecting in relation to CP? I'm asking. Why you mentioned?
Sir, I just asked. I'm not sure. I don't know if it had any correlations.
You should, if you have any causes in the causes of CP, if you have any neurocutaneous syndromes are involved in the causation of CP, then you should have asked. Okay.
Okay. Yes.
Not in other way. Otherwise, skin appears normal means because these babies, because of prolonged bedridden, they will have
sores could be there.
Sores, decubitus ulcers.
No, sir. None of it was present.
Those things are important rather than neurocutaneous markers.
Yes, sir. Yes.
Okay, long-term bedridden. Those issues will be there. Okay. That's why if you are asking something, you should know. That's why you should be able to.
Yes.
Yeah. Next slide.
So then, next to systemic examination.
Next to systemic examination, head to toe examination is finished.
Yes, sir.
Because you have not mentioned the posture of the baby in the head to toe examination, how the baby was placed. You told only the baby was examined in supine position. Because with so much, because posture only you can diagnose so many things. How the baby was placed, how are the legs, over the neck, whether the neck is deviated to one side, whether the neck is deviated to back side, whether the neck is like that. Because those things will roll out from with the hand, position of the hand, or with the position of the knees. That is important. Whether the knees are close together, whether the knees are wide apart, or with the position of your hip. Those things will give so much clue. Whether it is spastic CP, all those things. In that diplegic CP, all those things. You got my point. Those things you have to mention here. Especially the posture is very, very important.
Yes, sir. Yes.
Next.
Next is a systemic examination. I'd like to start with sentinel system examination. So for higher motor function, I could assess only speech and language, which was poorly developed, and the child was conscious, but it was very irritable. I couldn't
what are
assess
the components you will look in the higher mental function?
Yes. Hello.
Yeah. What are the components you will look in the higher mental function?
Sir, first to start off with speech and language, memory.
No, first thing is what your look is appearance, how the child is appearing.
Yes, appearance.
Then you look for a behavior, how the baby is behaving. Those things will be more appropriate. There only you can assess because the first thing is always level of consciousness.
Sir, consciousness, then cognitive functions we assess, then appearance and behavior of the child, then mental and emotional state, then speech and language, then speech and language.
Then orientation, memory and all, it's very difficult to check here.
Yes, sir.
Okay. What speech abnormalities you can get in your CP?
Sir, CP can have certain oromotor dysfunction, so he'll have inability to express.
Yeah, inability. What type of speech abnormalities? Because definitely one of the comorbidity of your CP is speech problems. What type of speech problems you can expect? There are different types of speech problems in there. Your motor aphasia is there, sensory aphasia is there. Your dysarthrias are there. What type of speech abnormality you are expecting here?
Sir, dysarthria.
Speech and language is poorly developed. In what way it is poorly developed?
Sir, speech, dysarthria.
Which one?
Like dysarthria. Look for dysarthria.
No, I'm not. Whether the baby is able to comprehend, whether the baby is able to listen to your word, like that. Because if there is a cortical lesion and all those things, baby is not able to listen to your word only.
Yes.
Because hearing also you should ask in your history. Whether the baby is able to appreciate any hearing, because hearing issue will be there. That's why you try to elicit those things in the history wise only. Because speech is going to be impaired if there is no hearing. That's why first thing is hearing is good or not.
Yes.
What type of speech abnormality you are expecting in a cerebral palsy?
Motor aphasia or dysarthria.
Motor aphasia is different. Dysarthria is different. Motor aphasia is what is motor aphasia? You are not able to. You can understand the word, but you are not able to talk properly. Repetition is what happened to the repetition? Repetition is impaired.
Got
my point? That is motor aphasia. You got my point?
Yes, sir.
Comprehension is good. The repetition is impaired. But it is a non-fluent speech. Non-fluent speech. That is motor aphasia. That is different. What is dysarthria? Dysarthria
is unable to phonate.
You can understand everything. Articulation defect. The way they produce the speech, it will be different. We'll have a staccato speech. We'll have a scanning speech. We have a slurred speech. All those things. You got my point?
Yes, sir.
If it is a cerebellar problems, cerebellum is a lesion. If it is suspecting, then they'll have a more of staccato scanning speech, more of explosive or more of break in the words, like that. You got my point?
Yes.
Very slowly they try to speak. You got my point?
Yes.
Slurred speech. If you're getting a slurred speech, a strangled speech, it's more of spastic, like the pseudobulbar palsy, like that. That's why you try to elicit where is the lesion by the speech. Speech. Automatically the language will be coming, and memory and all those things you can't check. And all those things you can't check. Only the language and the speech you are going to check. That is important. Attention also it's difficult. The level of consciousness is very important. How will you define the level of consciousness?
Sir, if the child has any spontaneous activity during examination, then he is conscious. I don't know how to.
Level of consciousness means you will do a Glasgow Coma scale. Usually the babies we are going to do a Glasgow Coma scale for level of consciousness. For orientation, we do a time, place, person. You'll ask question because here the baby will not respond to your words. We not may. That's why whether the baby, how the child behaving, how the child appearing, all those things will give us so much important. The mood of the child. Okay, the mood of the child is very, very important here. You mentioned that one, irritable. Just the mood or a behavior. Behavior is important. Okay. Try to get those things in the higher mental function. There also you can come to know where is the lesion in the brain. Okay. Cranial nerves.
Sir, cranial olfactory we weren't able to assess.
Able to assess. Below 5 years you can't assess.
Yes, sir. Sir, for optic nerve we did the visual confrontation. The child was able to
the visual confrontation for normal. No, you can't do visual confrontation for. How you know that? She told that I'm appreciating it much.
No, sir. Like
baby can't speak well
her hand. Yes, sir.
Raise her hand. So much weakness is there.
Sir,
so much head lag is there. How will you raise their hand?
Yes.
You cannot done the visual confrontation. Simply you wrote. I think better if you have done the fundus examination. Then it will be more appropriate. Or moments, if you have checked anything, moments of the eye movement, glass movement, because visual confrontation test is where you are going to check the angle, degree.
Yes, so we just ask the child to follow the
appreciate the movements, eye movement. That's all. You can't elicit visual confrontation. Yes, the child will not. The child is able to respond to your comments.
No, sir. No, sir.
No, then how you check the visual confrontation?
No, we just asked. We saw if the child could fix it on the hand if he moved it. Sir.
No. That's very difficult. And don't comment on those things. Then.
Sir, cranial nerves 3, 4, and 6. The pupils are equal, round and reactive to light, and conjugate movements of the eye were normal.
Just you appreciate the movements were normal. There are no strabismus,
no sir. No nystagmus, no strabismus.
Face is symmetrical.
Yes,
there are no lesions. Okay.
No, sir. Sir, for vestibulocochlear nerve, we just made sounds without the child seeing it, and it just moved its head towards the sound.
Move the head? I'm not getting up.
So the child.
Yeah.
So the child just moved towards the loud sounds that we produced.
No, how will you produce the sound?
Sir, by clapping. By clapping or. Yeah.
No, clapping means definitely will be seen in front of you. Definitely the
child is while standing behind the child.
You should tell how much behind you. How much behind. How much behind, that is important because if you are 1 meter, 10 meter, because for decibels, we have to know whether it is only 10 decibels, 5 decibels, 65 decibels, all those things. Because always, if you are checking a vestibulocochlear nerve, you should stand behind the patient, not in front of the patient. If you do like this, then it will not be appropriate.
Yes,
stand behind the patient and they should do like this or small sound, whispering sounds, whether the baby is able to appreciate with the baby. It's very difficult to do for the CP child. Started by loud noise means where and how, all those things are important. Because definitely they'll have some hearing issues will be there sometimes. If it is a quadriplegic.
Yes, sir.
No difficulty in swallowing, no drilling of saliva, no sensation. There is no cranial nerve involvement.
No, sir. No
cranial nerve involvement is not there means there is no involvement of brainstem.
Brainstem. Yes.
It is more of now. It is only the cortex is involved.
Yes, sir.
According to you. Okay, next.
So then.
Next slide.
So then we did the motor system.
Motor.
So there's a typo, sir. It's 12 centimeters upper limb.
No, motor system you examine. No, you examine the upper limb.
Yes, sir. I'm sorry. Okay, no, sir. The bulk of the upper limbs.
No. Bulk. You can't comment like this. Bulk.
Okay.
Bulk. If you have to comment in the both, you have to mention the upper arm, the forearm. Everything you have to mention. You have to mention in relation to the shoulder, in relation to the arm, like that.
Okay.
It's not like 15 centimeter both the arms, lower limb question mark. What is that question mark?
Sir, no, sir. That is I forgot to save the changes. It's somehow corrected. I'm so sorry.
Okay, bulk. What the bulk will suggest? Bulk.
Sir, suggests
both the inspection as well as the palpation.
Palpation.
Palpation, you are going to measure. in the bulk, whether any visible wasting, all those things you can appreciate.
Yes.
Atrophy or all those things you can appreciate. But you are mentioning 15 centimeter both arms, lower limb also normal. Therefore, there is no asymmetry in your.
No asymmetry. Yes, sir.
No asymmetry. Therefore, entire all the limbs are equally involved.
Yes. Sir.
Therefore, it is somewhere in the cortex. The lesion is maybe in the cortex. Okay. Tone.
Sir, tone in upper, we checked individually for upper limb in all the joints.
All the joints are checked. Hypertonicity in all the 4 limbs associated with spasticity.
Yes, sir.
You are mentioning hypertonicity, that is hypertonia in the form of spasticity.
Yes. No. Yes, sir. Yes, sir.
In all the 4 limbs.
Yes, sir.
What are the other hypertonic things? You know.
Sir,
because you have mentioned other hypertonicity.
Sir, like clasp knife rigidity.
No. Clasp knife, it is not rigidity. It is always spasticity.
Spasticity, yes, sir.
Clasp knife. If you mention hypertonicity in all the 4 limbs associated with spasticity, you have mentioned. No. Okay.
Yes, sir.
Therefore, the hypertonicity is in the form of spasticity. You have mentioned. Therefore, any other hypertonicities are there? I am asking.
Sir, I don't know, sir.
No, your rigidity.
Okay, rigidity.
Your dystonia. Your dystonia is also the hypertonia. Okay. Your rigidity is also hypertonia. Your spasticity is also hypertonia.
Okay.
So, now how will you differ this spasticity, your rigidity, and your dystonia?
Sir, in spasticity, when it is velocity dependent.
How will you do that velocity dependent?
Sir, when you rapidly try to move, when you passively move the joint, there is resistance first, and then you can move the joint. In case of rigidity, you have that cogwheel rigidity and lead pipe rigidity. In cogwheel, there is like stop.
There's hypertonicity in all the limbs. Okay.
Yes.
Yeah, you are. Which muscles are affected here? Whether the flexor group of muscles are affected or extensor group of muscles are affected.
Okay, sir.
Because you have mentioned hypertonicity, I don't know whether it's because I have not seen the kid, whether the tonicity is more in the flexor group of muscles or whether the tonicity is more in the extensor group of muscles. Because the lesion, it all depends upon the where is the lesion.
Okay, sir.
That's why whether tonicity is in the upper limb, whether it is the flexor group of muscles or extensor group of muscles. In the lower limb, whether it is in the flexor group of muscles or in the extensor group.
Yes, sir. Yes, we'll ask that. We have to ask. I did not ask.
No, you can't ask. You should.
No, we should do it, sir. Yes.
Elicit. That's why we are whether the upper limb predominantly your flexor group of muscles are affected or a extensor group of muscles are affected. Because how the position of the baby is very important. Where is the brain lesion? Because in the upper limb the flexor group of muscles are more affected.
The
lower limb the extensor group of muscles are more affected.
Yes,
it's more of those things, pyramidal tract involvement.
Okay, sir.
Point.
Yes,
only the extensor group of muscles are involved. That's why you have a hypertonia assessment tool. In that hypertonia assessment tool, we can know whether it is a spasticity, whether it is a rigidity, whether it is a dystonia. So try to elicit that one. You have to differentiate because dystonia is more in case of extrapyramidal. Rigidity is more in extrapyramidal.
Yes, sir.
Spasticity is a feature of pyramidal feature.
Pyramidal tract, yes, sir.
UML lesion. Therefore, because we have to know whether the lesion is in the extrapyramidal structures or in the pyramidal structures.
Pyramidal, okay.
Now your history is going in favor of a pyramidal structures.
Pyramidal, yes.
But you should know whether the for this one.
Okay.
And power also you can't write. No, power also you can't like 3+ in all the 4 limbs.
Okay. Individual muscle groups.
No, it all depends upon the what arm, shoulder joint, elbow joint. In that way, you should mention.
Okay, sir.
Adduction, abduction, flexion, extension, everything you should mention.
Yes, sir.
All those things and all the muscles you are having 3+ only.
Yes, sir.
All the muscles.
Yes, 3+. Sir. I mean, only against gravity, against resistance, the child can't push.
How do you grade that one? Power?
Sir, power, yes, sir. Just one minute. Sir, +5 is against.
No, you come with 0.
Yes, 0 is no movement.
No movement.
+1 is just flicker of movement.
Yeah, flickering of movement.
+3 is against gravity.
+1 already going to a 3. 2. Where is 2?
Sorry, +2. There is, if once gravity is removed, then there is movement. And +3 is against gravity, he can move, and +4 is with resistance. He can.
+4 is with resistance. +5 is not there. Grade 5 is not there.
Grade 5, yes, sir.
Then you are not missing the grade 5, huh? You are correct, no? Huh?
Yes, sir.
Missed the grade 5. Then
so
once again you repeat.
Okay, sir. Grade 0 is there is no the child does no movement. Grade 1 there is only just a flicker of movement. On grade 2 is just when gravity is eliminated, he is able to move. Grade 3 is move against gravity but not against resistance.
Yeah. 4 is
against resistance, and 5
against
is normal
partial
power.
resistance. Against partial resistance. We can't use the full. Against partial resistance. What is the grading is called?
Sir, MRC grading, I think.
Yeah,
Medical
Research Council
of
London.
Research Council. Yes, sir.
Medical Research Council of London. That is the grading of the muscle weakness. That is very, very important. Here, grade 5 is there. You have mentioned 3. That is able to move against gravity, but not against. How will you check those things in all the limbs? In all the limbs, you check that one 3+.
Sir, in the lower limbs, you try to hang the child. You try to hang the legs from the edge of the bed.
Okay.
And
then what the baby was doing there? Because
so then if he can,
so much hypertonicity is there, whether the baby is able to move, whether the baby is able to move. Because for this, you should show the videos. Then we can know whether you assess the baby or not properly. Because for all those things, examination point, it's better to show this one.
Yes, sir. Again,
then that shows more accuracy in your examination.
Okay, sir. Okay.
3+ you can't write like that. You should write properly in the Chapner column, and you should mention. Okay.
Yes, sir. Sir, and Babinski sign was positive in both feet.
No, Babinski sign, only Babinski sign you have done. You have not done any other signs. Why Babinski sign is positive in both the feet? Why, if it is only one feet, if it is Babinski sign positive, means what does this suggest?
Sir, if it's asymmetrical, then it becomes significant.
Asymmetrical is significant. It's, symmetrical means not significant.
Sure.
No, I'm asking if the Babinski sign is positive in only one, in other limb it is not present, or if the baby is having all the features are there, but Babinski sign is absent. What does it suggest? If all the features of human lesions are there in the body, but Babinski sign is negative. What is the Babinski sign in the upper limb is called?
Sir, it is.
It is.
I'm not sure.
Especially in the CP, which one? You are not mentioned about those things. CP.
Okay.
Especially in the CP, your cortical thumb is there, no? Cortical thumb. Cortical thumb. That is unfisting of your thing.
Okay.
And that is the equivalent of Babinski sign in the lower limb. Okay.
Okay.
Persistence of that one cortical thumb is the baby is not able to. That you have to comment. When the baby opened the hand, all those things you have to ask. In your And you have mentioned deep tendon reflex is 3+3+3+3+3+. What do you mean by 3+?
Sir, it is a brisk response.
How do you grade DTRs?
Sir, so grade 0 is there is absence of deep tendon reflexes.
Okay.
Grade 1 is sluggish, or if when you do gender-sick maneuver, then you can see the response.
Okay. Grade only by reinforcement.
Reinforcement, yes, sir. 2 is readily elicitable, and it's 2 is like the normal ankle reflex. 3 is brisk or an increased response, and 4 is clonus, exaggerated or clonus.
Exaggerated clone. How will you elicit the clonus? What are the different types of clonus?
It is generally elicited at the ankle.
Ankle. Okay.
So you externally rotate at the hip and dorsiflex the ankle quickly, so that there is clonus that you feel.
Then, how much movement should be there to call true clonus? Pseudoclonus. Pseudoclonus.
I'm not sure, sir.
How much movement should be? Suppose normally also some 1-2 movements will be there. when you call significant clonus, that is also you should know. And deep tendon reflexes you have mentioned directly. You have to mention because motor system examination, it is like bulk, tone, power, coordination, and the involuntary movement. These 5 components will be there here.
Okay, sir.
Deep tendon reflexes will be separate.
Okay, sir.
What my point? Bulk, tone, power, your involuntary movements, and the coordination. All these things will come here.
Okay.
Since the power is more than 3 plus, you have to go for your involuntary movements assessment as well as your coordination assessment also.
Okay.
Because we want to know whether the baby is having any coordination movements. If the power is more than 3 plus, if the power is less than 3, we can't do anything.
Yes.
It is less than 3 or 3 also. 3 plus you have mentioned, no? That's why.
Okay, sir. Okay.
That's why you have missed coordination and the involuntary movements assessment.
Okay.
Involuntary movement, because these babies there'll be more. Sometimes we'll get a dyskinetic also. Athetoid.
Okay.
If you should how to elicit athetoid movements, how to elicit chorea movements, what makes trigger the involuntary movements. All those things you try to elicit. Okay.
Yes.
Not proper. In the reflexes, you have to mention superficial reflexes and deep
tendon. Yes.
Deep tendon reflexes. Okay, superficial reflexes. In that, you have to mention the conjunctival, your abdominal, your Babinski. All those will be in the Babinski. You have to mention it is extensor plantar response. You have to be more appropriate.
Okay.
What do you mean by minimal Babinski? Minimal plantar response.
I don't know.
Minimal plant. Okay, you should know how to elicit the Babinski sign, how to stroke the sole of the foot, all those things.
Yes, sir. Yes.
What is withdrawal, how to hold everything you should know. Next, sensory system.
Sir, we couldn't assess because the child doesn't respond. Only on pinching and painful stimuli he just withdraws, sir.
Why you are not elicited the cortical sensations?
Sir, the child is unable to just respond to us in any way, so I didn't know what to do.
No, unable to means if you're not the baby is not unable to do anything. Because you are told able to move against the gravity but not against the resistance. You told baby to move or baby was moving. Because cortical sensations we want to know whether the cortical sensations are intact or not. Whether you are given any ball to identify baby, whether baby was able to appreciate that ball, maybe in toy, baby was able to appreciate the toy. If you give some toy, whether the baby is able to reach for the toy.
Okay, sir.
All those things you have to elicit that show the weakness.
Yes, sir. Yes.
Whether the weakness is there, whether which muscles are involved, more proximal group of muscles, distal group of muscles.
Okay, sir.
Whether the truncal muscles. You're not mentioned about the head and neck also. Head and neck muscles are also very important. Truncal muscles are also important. Because in this maybe you have to do a 180-degree examination. The supine, pull to sit, sitting. Then your ventral suspension sometimes. Maybe weight is 10 kgs, no?
Yes, sir.
Least. Then gait and cerebellar signs could not be elicited. No signs of meningeal irritation. You never expect the meningeal irritation in a CP, no? No need to mention about those.
Okay, sir. Okay. Yes, sir.
And separately you can mention about the cranium and the spine. That is skull and the spine. You have to examine skull and the spine separately.
Okay. Yes.
Okay. Next slide.
Sir, then other systems.
Other systems examination. Cardiovascular system was normal.
Yes, sir. Yes, sir. Other systems there were no
normal
abnormalities.
Okay. Then what's your last diagnosis?
Sir, diagnosis. This is a.
Come to last slide.
So this is a 4-year, 11-month-old child with spastic quadriplegic type of cerebral palsy with grade 4 malnutrition with wasting.
If you have mentioned grade 4 malnutrition, why you use the 3rd-degree wasting,
yes, sir,
all those things?
Yes, sir. Okay.
No need to use.
Okay.
No, you have mentioned. I told you it is a spastic. That is spastic means you have mentioned the physiology.
Yes, sir.
And the quadriplegia, you have mentioned the anatomy. Type of cerebral palsy, you have mentioned anatomy. You have not mentioned how much functional impairment he had.
Okay, sir.
How much functional impairment, whether he's not able to do any activity, no, it's completely dependent on the mother.
Yes, it's completely
because it is an activity limitation.
Okay.
What
Yes, sir.
grade of limitations for your UG level? Because we have so many other scales. Gross
Okay,
motor function classification system, EDAC system for eating, drinking,
okay,
MAX
sir.
system for hand movements. So many things are there. But
Okay, sir.
for your undergraduate level, at least there should be physiology, there should be anatomy, there should be etiology, there should be function with comorbidities.
Okay,
Comorbidities,
sir.
you have mentioned malnutrition, one comorbidity,
Sir,
and you have
global
mentioned
developmental delay.
global developmental delay. Because if it is a cerebral palsy, if you use the word, it is indicated that it is a global developmental
Okay,
delay.
sir. Okay.
Okay. Usually we don't use, if you're using a cerebral palsy terminology, it goes more in favor of a global developmental
Global
delay.
development. Yes, sir. Yes.
Got my point. Because
Yes, sir.
if it is a only motor delay, the etiology will differ. Some
Okay,
other
sir.
thing. You got my point.
Yes,
If a
sir.
global developmental delay only cerebral palsy.
Yes, sir.
Global developmental delay will be more. That's correct. You can mention in the development, you can mention global developmental delay. That is also correct. Sometimes very motor development will be more delayed than compared to
Okay,
cognition,
sir.
cognition, language, and the social. Language and the phone. Then one more, no need to mention that third degree wasting, severe stenting,
Yes, sir.
and microcephaly.
Microcephaly.
Two previous episodes of convulsions. You can't write this one because you have to write what is the cause for this seizure.
Okay, sir.
Got my point?
Should I write it as epilepsy then, sir?
Epilepsy. What do you, then you should know what is the definition of epilepsy.
Sorry,
If you are
more
knowing that,
than or equal to 2 episodes of seizures.
no, more than or two equal. That is not the definition for epilepsy. That is not the definition. More than or two, because if you don't have a provoked nature, then
Oh, not unprovoked, which are unprovoked. Yes.
which are unprovoked. How much duration apart? 24 hours apart.
24 hours apart. Yes, sir.
Then those things are not fit in your this one only.
Okay, sir. Okay.
There you had one insult. You got my point. Whether it is
Okay,
seizure disorder or epileptic disorder, we don't know. If it
Okay,
is
sir.
an epileptic disorder, in that epilepsy disorder, whether it is a structural disorder, whether it is an immune disorder, whether it is a metabolic disorder, we don't know exactly.
Okay, sir.
And mention here it may be a seizure disorder because he had only 2 episodes that were not significant. Epilepsy is one where we will get repeated, recurrent.
Recurrent.
He had seizure. He had
Okay.
seizure, which is of you don't know whether it is GTSS type, whether it is chronic type. Also, you don't know because you have mentioned only the convulsions.
Convulsions.
Yeah, you have not mentioned entire thing. Therefore, any other thing you have to mention here, secondary to birth asphyxia you mentioned. But
yes, as etiology.
You mentioned the secondary to birth asphyxia. But usually what happens, we don't know. Sometimes prenatal insult may be there. Along with that baby, if the baby is coming out, they'll have a perinatal insult also.
Okay.
Some prenatal
Yes.
issues may be there, but you have not evaluated those prenatal issues. This one, with microcephaly, with all those things, and your NICU stay was not that much adequate. Not describe entire thing in the NICU because NICU stay. If the birth asphyxia baby is there, mean definitely, especially if it is severe birth asphyxia of the baby, definitely the baby would have stayed for like 10 days or 15 days like that. Baby may be ventilated. All those things, history is not there. You got my point?
Yes.
If it is a birth asphyxia is involved, it's more commonly birth asphyxia will more involve the basal ganglia region. Okay. If it is a more your cortex is involved, since it's a quadriplegic type of CP, it is a global.
Yes.
Global involvement. Therefore, here it's more of periventricular leukomalacia, severe periventricular leukomalacia, like that. It will go. And it's a term baby.
Yes, sir.
The term baby. Usually in the preterm babies, we'll have more of periventricular because blood vessels are more fragile.
Yeah.
That's why your diagnosis will not fit all those things. And you should mention about our vision and the hearing.
Hearing. Okay.
Because vision and hearing. And you should mention about the feeding problems. Sometimes they are more common with feeding problems. They'll have GERD. They'll be keep on regurgitating the food. They'll have constipation issues. They'll have because comorbidity. There are so many comorbidities. Right from top to bottom.
Osteoporosis.
They'll have a dislocation of your hip joint. Sometimes stiffness. You are telling stiffness from notice. Therefore, they'll have a dislocation of the hip joint.
Okay.
Therefore, you have to comment on the hip. You are not commented on all those things. Okay, whenever you are commenting on all those things, whenever you are writing diagnosis, you should comment all those things are important. Even behavior.
Okay, sir.
Behavior, because some it may be associated with ADHD, autism, like that. Irritable,
Okay.
they'll keep on irritable. They won't mingle with anyone, like that. Vision, if it is
Sure.
convulsions, if you are describing, it's very important whether it is what type of convulsions, whether it fits into any syndromes, like that.
Okay.
Got my point? All
Yes, sir.
those things. Therefore, for a complete diagnosis, you can write first is global developmental delay,
Yes.
with spastic quadriplegic type of cerebral palsy,
Okay, sir.
with microcephaly, with
Yes, sir.
convulsions. It is in the form of GTCS, but exactly we
Okay.
don't know the cause for that. This one, with no hearing, no vision, no behavioral abnormality, no orthopedic issues like contractures. You got my point? With
Yes.
grade 4 PM, grade 4 PM, it is a severe acute malnutrition. You got my point?
Yes, sir.
All those things you should mention here. Okay. Your
Yes, sir.
mainly vision and hearing is very important. We should put in, because this is
Okay,
normally associated with the cerebral palsy.
sir.
Overall,
Yes, sir.
very good. You have tried your best.